Psychosocial integrity. The practical vocational nurse provides care that assists with promotion and support of the emotional, mental, and social well-being of clients. The licensed practical nurse must be able to assist in or reinforce education to caregivers, family, on ways to manage client with behavioral disorders. Participate in behavior management program by recognizing environmental stressors and/or providing a therapeutic environment. Participate in reminiscence therapy, validation therapy, or reality orientation. Participate in client group sessions. Identify signs and symptoms of substance abuse, chemical dependency, withdrawal, or toxicity. Collect data regarding client psychosocial functioning. Identify client use of effective and ineffective coping mechanisms. Identify stressors that may affect recovery, health maintenance, for example, lifestyle, body changes, or environmental. Assist client to cope, adapt to stressful events and changes in health, for example, abuse, neglect, end of life, grief and loss, life changes, or physical changes. Collect data on client's potential for violence to self and others. Assist in managing the care of angry, agitated client, for example, de-escalation techniques. Make adjustment to care with consideration of client's spiritual and cultural beliefs. Explore why client is refusing or not following treatment plan. Assist in the care of a client experiencing sensory perceptual alterations. Assist in the care of a cognitively impaired client. Promote positive self-esteem of client. Provide emotional support to client and family, and use therapeutic communication techniques with client. Client abuse and neglect. Abuse and neglect can take on physical, psychological, and financial forms. The types of abuse and neglect are sexual abuse, physical abuse and neglect, psychological abuse and neglect, and financial abuse and neglect. The term elder abuse refers to any physical, psychological, sexual, or financial abuse that is carried out against an elderly person. Domestic violence entails the use of physical, psychological, sexual, or financial abuse against a spouse, family member, or significant other. Child abuse and neglect includes acts of violence or neglect against children that can include physical, psychological, sexual, or financial abuse, as well as physical, psychological, and financial neglect. Physical abuse can include things like punching, burning, and twisting limbs. Psychological abuse can include things like threatening harm to another, locking a person in a room, and bullying. Sexual abuse includes all sexual contact that is not agreed to by one party. Financial abuse is withholding funds that belong to another and abusing things like a power of attorney for the person's own gain without regard for the needs of the victim and their welfare. Examples of physical neglect can include things like not providing physical care and not providing for the physical needs of the victim when the abuser has the responsibility to do so. Psychological neglect can include things like isolating the victim for others and isolating the victim in their own home, away from other members of the family unit. Financial neglect is not providing the victim with basic and essential needs, even though ample financial resources are available to provide for these needs. Identifying the signs and symptoms of physical, psychological, and financial abuse and neglect in the client. The signs of physical abuse include physical injuries such as fractures, burns, cuts, and bruises. The signs of psychological abuse can include depression, apathy, isolation, and withdrawal. The signs of financial abuse can include shabby dress attire and poor basic hygiene and grooming. Signs like a weight loss or a failure of a child to gain weight according to the norms can indicate the presence of a physical, psychological, and/or financial abuse or neglect. The lack of family involvement in the care of a patient can indicate the possible presence of all of the types of abuse and neglect. Recognizing risk factors for domestic, child, and/or abuse, neglect, and sexual abuse. Recognizing risk factors for domestic, child, and/or elder abuse, neglect, and sexual abuse. Some patient populations are more at risk for abuse and neglect than other populations of patients. For example, females, pregnant women, infants, children, cognitively impaired individuals, the developmentally challenged person, those with physical or mental disabilities, and the elderly are at greater risk for abuse and neglect than other patient populations. Some of the traits and characteristics associated with abusers include substance abuse, a psychiatric disorder, poor parenting skills, poor anger management skills, poor self-esteem, poor coping skills, a personal history of abuse and/or neglect, poor impulse control, and the presence of a current crisis. The perpetrator's past history of their own abuse and neglect is perhaps one of the strongest forces that lead these people to abuse and neglect others. In terms of spousal abuse, the cycle of violence, also referred to as the cycle of battering, consists of the honeymoon phase of calmness and peace, the tension-building phase, the explosion phase in response to a trigger, and then finally, the reconciliation phase, which begins this endless cycle all over again unless treatments and interventions are successful in terms of preventing it. Providing a safe environment for abused and neglected clients. In addition to nurses' mandatory reporting, other interventions that provide a safe environment for abused and neglected patients include interventions such as safety planning, the identification of resources in the community, and psychosocial support of the nurse and other members of the healthcare team within a trusting, open, supportive, and non-judgmental professional relationship. Very often, neglected and abused children are removed from the home and placed in an alternative setting by law enforcement authorities. Abused spouses and intimate partners may be referred to a safe house. The elderly affected with abuse and/or neglect may be removed from their current home to protect these vulnerable victims. Providing emotional support to the client who has experienced abuse or neglect. Nurses and other healthcare professionals not only provide physical care to patients in terms of their physical care, they also provide emotional support and encourage enhanced coping skills among victims. The experience of abuse or neglect is a traumatic psychological crisis that must be addressed as such. The healthcare team must emphasize the fact that the victim has not done anything wrong. They must also emphasize the fact that the victim's life and the lives of their children can be in danger if the abuse is not addressed. It will not disappear with a lack of action. An order of protection against the perpetrator is often recommended. Reinforcing teaching related to coping and coping strategies. Abusers and victims alike need the reinforcement of teaching relating to coping and coping strategies. For example, abusers may need reinforcement about the need to attend anger management or parenting classes. Victims, on the other hand, may need reinforcement about the need to separate from the abuser to prevent the ongoing and endless cycle of violence. Evaluating client responses to interventions. The evaluation of the patient's responses to interventions determines how effective the care of the victim has been. For example, nurses determine whether or not serious and non-serious physical injuries are treated and stabilized. Nurses determine whether or not the patient has made decisions relating to their safety plan. Nurses also evaluate the patient's responses to psychological interventions and support. Were these interventions effective in meeting the patient's expected outcomes? Behavioral management. Monitoring the client's appearance, mood, and psychomotor behavior and observing for changes. The client's appearance, mood, behaviors, and changes of these indicators gives nurses rich data and information about the patient, their current state, and possible adverse behaviors that have to be managed before they occur. Reactive behavior management is far less effective than proactive behavior management that prevents poor patient behaviors. The patient's appearance is monitored in respect to the person's posture, gait, hygiene, grooming, and other things like the appropriateness of their attire. The patient's mood and effect are mentioned by interpreting their verbal and nonverbal communication. For example, is the patient's mood happy, elated, somber, sad, depressed, or flat and without any emotion whatsoever? Is the patient making eye contact, making any facial grimaces or unusual sounds, and/or having any unusual bodily movements that can indicate the patient's mood? For example, pacing may indicate agitation, anger, hostility, and/or restlessness. Exploring the causes of inappropriate client behavior. As nurses explore the causes of inappropriate and dangerous behavior, they consider environmental, physical, psychological, and social factors that may trigger and provoke these behaviors for their patients. Some of these environmental forces and factors that can precipitate inappropriate and dangerous patient behaviors can include hot or cold ambient temperatures, noxious odors, noises, and lights. Physical forces and factors that can precipitate inappropriate and dangerous patient behaviors can include physical illness, pain, fever, fatigue, and sensory or perceptual disorder, such as impaired sight and hearing. Some of these psychological forces and factors that can precipitate inappropriate and dangerous patient behaviors can include the presence of an existing psychiatric mental disorder, delusions, delirium, psychological trauma and crisis, and abuse. Additional explorations into the causes of inappropriate and dangerous behavior include the determination of events and situations that were present just prior to the behaviors, where the behaviors occurred, when and what time of day the behaviors occur, and what environmental factors may have contributed to the triggering of the event. The best way to incorporate all of these forces and factors into your determinations is to know your patients and the things that tend to trigger them into poor and inappropriate behaviors. Assisting the client with achieving self-control of behavior. Nurses assist clients with achieving their own self-control of behavior with a number of different strategies, including behavior modification, modeling, desensitization, operant conditioning, contracting, and aversion therapy, among other strategies. Behavior modification is a planned and systematic intervention that aims to change the patient's behaviors with the consistent reinforcement of positive and adaptive behaviors with praise and rewards, and the consistent use of negative reinforcement for negative maladaptive behaviors, such as acting out. Modeling gives the patient an opportunity to observe and mimic appropriate behaviors that are most often provided by the psychological therapist. Desensitization is the purposeful and systematic exposure of the patient to progressively more provocative and intense stimuli so that the patient can learn how to cope with these stimuli in a progressive manner with the support of those involved in the care of the patient. Operant conditioning, akin to Skinner's theory, is the provision of positive reinforcement and rewards for appropriate behaviors. Contracting entails a formal written and signed contract that details what the patient can and cannot do. Aversion therapy is the use of negative reinforcements, such as the cessation of privileges, when the patient demonstrates inappropriate or dangerous behaviors. Assisting the client in using behavioral strategies to decrease anxiety. Behavioral strategies to decrease anxiety include cognitive reframing and a wide variety of stress management relaxation techniques like those that we will discuss now. Cognitive reframing is done to teach the patient to stop negative thoughts by consciously replacing these negative thoughts and impulses with positive thoughts. Meditation is deep focus and thought. Meditation is often difficult for beginners because they are not used to sitting quietly with nothing other than one's own thoughts. But with practice, most people can master this deep focus and thought. Meditation can be done anywhere and at any time provided that the person is not easily distracted. Many cultures and religions use meditation for spiritual and religious purposes. Prayer is a formalized form of religious meditation. Like meditation, prayer requires deep focus and thought. Journaling provides the opportunity for people to record and document their feelings and thoughts. At times, people incorporate events or interactions that trigger their feelings and thoughts so that, at a later date, the person can look back over their journaling entries to identify patterns or trends. For example, the person may notice that their stress and anxiety increases when they are tired or when they are interacting with a particular person. Deep breathing consists of taking deep and cleansing breaths while using the diaphragm. The procedure entails taking as deep a breath as possible, holding it, and then slowly exhaling while thinking peaceful thoughts. Progressive relaxation involves contracting and releasing all muscle groups in the body. Most people begin with their feet. Then they work their way upward in an orderly and systematic manner. The procedure for progressive relaxation involves contracting and creating tension in the muscle groups and then relaxing and releasing the muscular contractions. Guided imagery is quite similar to meditation. In fact, guided imagery is often used with meditation. Guided imagery involves the person's visualization of a peaceful scene like a sunset or a quiet beach with rolling waves while they think peaceful thoughts. Music therapy can be used alone or in combination with other anxiety-reducing techniques such as deep breathing, meditation, and guided imagery. Biofeedback is not done as often as the other stress management and anxiety-reducing techniques. Biofeedback involves the patients being hooked up to externally placed electrodes and then connected to a visual display of the patient's heart rate, pulse rate, body temperature, breathing, etc. when exposed to stressors. The patient then performs some relaxation techniques, such as deep breathing, as they watch their internal bodily control over these bodily responses to stress. Mindfulness entails becoming acutely aware of the environment and the person's immediate surroundings to gain insight into it as anxiety is reduced. Resetting priorities allows the person to think about and renumber their priorities so that things can be manageable and put into perspective. Assisting in and reinforcing education to caregivers, family on ways to manage client with behavioral disorders. Caregivers, families, and friends often provide a support system for the client when it comes to coping with and adapting to psychological disorders, such as those requiring behavior management. These supports should encourage the patient to use positive behaviors. They should provide the patient with support and compassion. They should know how to prevent and de-escalate inappropriate behaviors. Nurses, therefore, should instruct and reinforce teaching for patients and their caregivers about all of these issues and the known triggers that precipitate the inappropriate behaviors for the patient, including environmental, physical, and psychological triggers. Participating in a behavior management program by recognizing environmental stressors and/or providing a therapeutic environment. Poor behaviors are best prevented within an environment that is without stressors and triggers that precipitate poor behavior. Milieu therapy, as well as the establishment and maintenance of a therapeutic relationship, can eliminate as many stressors and triggers from the environment as possible. Milieu therapy entails the planned and systematic changing of the patient's environment so that the patient has the opportunity to better cope and adapt when all extraneous variables in the environment are eliminated. When these factors are consistently eliminated, the patient is better able to identify and stay in keeping with the established boundaries and rules. They are better able to avoid stressful stimuli and triggers. They are better able to participate in appropriate activities and communication. Participating in reminiscence therapy, validation therapy, and reality orientation. Some of the therapies that are appropriate to meet the special needs associated with stress and anxiety include reminiscence therapy, validation therapy, and reality orientation. Reminiscence therapy is the sharing of life stories, memories, personal biographies, and histories with others. Reminiscence therapy gives the person who is sharing their story an opportunity to not only relate historical facts, but also to share how they felt about and coped with the events of their life. Reminiscence therapy gives the person a feeling of self-esteem and value. Validation therapy is beneficial to patients because it allows the patient to resolve conflicts and issues as the therapist recognizes and empathizes with the patient's experiences and responses as conflicts and issues are resolved. Reality orientation promotes the patient's identity, the time, and the place. Reality orientation is most often used among patients who, as a result of a temporary or permanent condition, are not oriented times 3 to person, place, and time. Participating in client group session. Nurses not only participate in group therapy sessions, but they also encourage their patients to participate in them. Group sessions facilitate the patients sharing their feelings, fears, concerns, and experiences with others. These things give patients the opportunity to vent. It also gives the participants an opportunity to provide feedback to the person who is doing the sharing. Reinforcing client participation in therapy. Therapy, including individual therapy, group therapy, and family therapy, is necessary for patient recovery and the prevention of relapses for psychiatric mental health disorders. All patients should be encouraged to participate fully in their group therapy sessions, and they should also be recognized and positively reinforced by the nurse and other members of the healthcare team when they do participate. Using behavioral management techniques when caring for a client. Behavioral management techniques, in addition to the behavior management strategies such as contracting and modeling that were previously discussed, are other strategies that can also be helpful to the patient. Some of these techniques, among others, are setting clear limits, setting realistic goals and expectations, and providing the patient with positive reinforcement with rewards and praise for positive progress and appropriate behaviors. Evaluating client responses to behavioral management interventions. As with the evaluation of all nursing care and patient responses to behavioral management interventions are compared to the pre-established expected outcomes to determine whether or not these interventions were successful in meeting these expected outcomes. Chemical and other dependencies. Substance abuse is one's overindulgence on a substance, which can be alcohol, prescription drugs, and/or illegal drugs. Some of the commonly used terms and terminology relating to substance abuse will now be defined. Chronic drug abuse is defined as the abuse of a substance that causes the person to have physical, psychological, social, and/or economic harm. Addiction is defined as the compulsive need for the person to have the substance. Addiction can occur with and without physical dependence. Psychological dependence is defined as the person's need to continue the use of the substance to avoid any unpleasant feelings and experiences that can occur when the substance is not taken. Physical dependence is defined as the occurrence of adverse, ill effects when the substance is not taken. Physical dependence does not necessarily indicate that the person is addicted. Identifying the signs and symptoms of substance abuse, chemical dependency, withdrawal, and toxicity. Drug-seeking behavior is a sign of substance abuse. Drug-seeking behavior is defined as patient behavior that the person uses to get prescription medications, such as narcotic pain medications. Some of the signs of drug-seeking behavior are the person's feigning pain or anxiety to get a prescription medication, the person's claiming that they have lost their ordered medication and they ask for another prescription, the person's use of forged prescriptions, the person's use of altered prescriptions, the person's illegally using a false form of identification to get medications from another provider, and threatening healthcare providers for not giving them their needed medications. Although the physical signs and symptoms of substance abuse vary among the different possible substances, there are some signs and symptoms of substance abuse that are commonly occurring. These signs and symptoms include track marks on the body, unkempt appearance, poor hygiene and grooming, hyperactivity, sweaty palms, cold hands, shakiness, and unusual breath and/or body odors. Some of the commonly occurring behavioral and emotional signs and symptoms of substance abuse, in addition to drug-seeking behaviors, can include moodiness, paranoia, forgetfulness, a lack of focus and attention, irritability, and nervousness. Some of the specific signs and symptoms specific to some of the commonly used and abused substances include: for opioids, tremors, diarrhea, fever, nausea, vomiting, bone pain, muscular pain, goosebumps, piloerection, pupil dilation, and muscle spasms are signs. Opioid withdrawal signs and symptoms can include high levels of anxieties, diaphoresis, muscular aches and pains, insomnia, a runny nose, abdominal cramps, diarrhea, and dilated pupils. Toxicity to opioids can be signaled with pinpoint pupils, bradycardia, slow, shallow breathing, a decreased level of consciousness, unresponsiveness, cyanosis, circumferential pallor, muscular spasms, and seizures. For alcohol, tachycardia, abdominal cramps, delirium, vomiting, and tremors are signs. Alcohol withdrawal can lead to a variety of physical and psychological or emotional symptoms when a chronic drinker suddenly discontinues drinking. Some of these signs and symptoms are mild, others are moderate, and still more can be severe. Some of the most commonly occurring mild to moderate symptoms of alcohol withdrawal are nausea and vomiting, pale and clammy skin, shakiness, nervousness, anxiety, depression, fatigue, nightmare, diaphoresis, headaches, a rapid heart rate, and tremors. Some of the most commonly occurring severe signs and symptoms of alcohol withdrawal are agitation, fever, convulsions, and at times, a very pronounced state of confusion known as delirium tremens. These severe symptoms can lead to injuries, and even death. For cannabis, tremors, abdominal pain, fever, irritability, aggression, and headaches are signs. For cocaine, agitation, depression, fatigue, cravings, and psychomotor slowness are signs. For amphetamines, hypertension, hypervigilance, extreme irritability, cravings, and depression, particularly when it is not used, are signs. For inhalants, the slurring of speech, a stuporous state, dizziness, and a lack of coordinated bodily movements are signs. For sedatives, nausea, vomiting, agitation, seizure activity, anxiety, and tremors are signs. Anxiety, seizures, hallucinations, uncontrollable shaking, and possible heart failure can occur when the patient is withdrawing from sedatives. The signs of sedative toxicity are anxiety, depression, psychosis, confusion, and panic. For hallucinogenic drugs, anxiety, dilated pupils, depression, flashbacks, a rapid heart rate, and panic attacks are signs. Planning and providing care to client experiencing substance-related withdrawal or toxicity. Depending on the substance, some patients can experience substance-related withdrawals and toxicities that can be life-threatening. In addition to physical monitoring and the care of the physical needs of the patient, such as the administration of medications for the signs and symptoms of withdrawal or toxicity, and the maintenance of the fluid and electrolyte balances, some general interventions for substance withdrawal and toxicity include the creation and maintenance of an environment that is at a low level of stimulation and without any potential for sensory overload, the creation and maintenance of an environment that is physically and psychologically safe for the patient, the ongoing provision of emotional support without any biases or judgments, the teaching of the patient, family members, and significant others about addiction and codependent behaviors. Assisting the patient with an emergency plan that they can use when they believe that a relapse is possible. Developing the patient's motivation and commitment to recovery and sustained abstinence, and facilitating the patient's attendance in frequent self-help groups like Alcoholics Anonymous and Narcotics Anonymous. In addition to referrals to self-help groups like Alcoholics Anonymous and Narcotics Anonymous, other behavioral interventions for patients affected with substance abuse and misuse include individual and group therapy, the development of a contingency management strategy that the patient can use, the development and maintenance of a therapeutic milieu and a therapeutic community that provides the patient with the support that they need, aversion therapy, and the development of a relapse prevention strategy. Patient education to avoid relapses. Patients who abuse substances are always at risk for a relapse. The relapse rate for this population of patients is disappointingly high, so ongoing support and education should be provided to prevent this negative outcome. Some strategies to prevent a relapse include the following interventions. Nurses should discuss and explore the positive effects of abstinence. Discuss and explore the negative consequences of continued substance use. Discuss and explore ways that the patient can recognize and avoid high-risk situations that may place them at risk for a relapse. For example, many patients benefit from avoiding people and situations that they had in their past when they were using or abusing substances. Work with the patient to develop the skills necessary for them to avoid any trigger situations and to be able to or cope effectively with abstinence when these trigger situations occur. Develop a relapse emergency plan in order to limit the length of severity of relapses should they occur. Involve family, friends, and other support people about who they and the patient can contact for help if a relapse occurs or a relapse is possible. Help the patient to identify and cope effectively with substance urges and cravings. Teach the patient about the steps they must take to reconnect with the services that they need during a relapse, and arrange for regular informal check-ins with patients that can help reduce potential problems before they become severe enough to threaten recovery. Providing care and support for client with impulse control disorders like gambling, sexual addiction, and pornography. Impulse control disorders, such as compulsive gambling, sexual addiction, and addiction to pornography, kleptomania, pyromania, shopping addictions, Trichotillomania and even addictions to work are often referred to as compulsive behavior disorders or process addictions. Some of the signs and symptoms of impulse control disorders include substance abuse, abusive behaviors towards others, aggressive actions towards others, destructive behaviors like the destruction of personal property and the property of others, inflicting self-harm, suicidal ideations and suicidal tendencies, compulsive theft and shoplifting, and other dysfunctional or maladaptive behaviors. The most common risk factors associated with compulsive behavioral disorders or process addictions include genetics, physical abnormalities, and an individual's environment. It appears that multiple members of one family may have a compulsive behavioral disorder. Therefore, it is possible that genetics play a role in this psychological disorder. Imbalances in specific neurotransmitters chemicals in the brain have been found among patients who are adversely affected by and diagnosed with impulse control disorders. Environment may also play a role. Environmental risk factors include growing up in and/or living in an environment that is affected with substance use, aggression, violence, neglect, and/or abuse. The two most frequently used treatments for impulse control disorders include cognitive behavioral therapy and/or drug therapy. Some of the drugs that can be used to treat compulsive behavioral disorders include selective serotonin reuptake inhibitors and antidepressants. Reinforcing information on substance abuse diagnosis and treatment plan to client. Chemical and other dependencies have a tendency to relapse. Although the recidivism or relapse rates vary among different substances and other addictions, nurses must be aware that relapses do occur. Therefore, nurses must be prepared to support and reinforce information about substance abuse and treatments in order to prevent a relapse. Nurses and other healthcare professionals provide emotional support and reassurance, educate client family about addiction and codependent behaviors, advise the family about removing prescription medications from home environment, facilitate the client's development of the motivation and commitment necessary for abstinence and recovery, help the client develop an emergency plan, and encourage attendance at self-help groups. Encouraging client participation in support groups like Alcoholics Anonymous and Narcotics Anonymous. Although there are other types of support groups in the community to address alcoholism and substance abuse, Alcoholics Anonymous and Narcotics Anonymous are perhaps the most well-known and the most often utilized support groups among those patients with a substance abuse disorder. Bill Wilson and Bob Smith founded and established Alcoholics Anonymous in 1935. Alcoholics Anonymous is a spiritual program that helps alcoholics to achieve and maintain their sobriety by attending group meetings and following the 12 steps of this non-religious but spiritual group. Those who attend Alcoholics Anonymous get the support of the other members or the group. In addition, they get the special guidance and support of their chosen sponsor, who has a one-to-one relationship with the alcoholic in terms of their recovery and sustained abstinence. Alcoholics Anonymous meetings are held throughout the world in the community, in healthcare facilities, in jails, and in other places. All members maintain the confidentiality of all other members, and they follow the 12 steps. The 12 steps of Alcoholics Anonymous are: 1. We admitted we are powerless over alcohol, that our lives had become unmanageable. 2. Came to believe that a power greater than ourselves could restore us to sanity. 3. Made a decision to turn our will and our lives over to the care of God as we understood Him. 4. Made a searching and fearless moral inventory of ourselves. 5. Admitted to God, ourselves, and to another human being the exact nature of our wrongs. 6. We're entirely ready to have God remove all these defects of character. 7. Humbly asked Him to remove our shortcomings. 8. Made a list of all persons we had harmed and became willing to make amends to them all. 9. Made direct amends to such people wherever possible, except when to do so would injure them or others. 10. Continued to take personal inventory, and when we were wrong, promptly admitted it. 11. Sought through prayer and meditation to improve our conscious contact with God as we understood Him, praying only for knowledge of His will for us and the power to carry that out. 12. Having had a spiritual awakening as the result of these steps, we try to carry this message to alcoholics and to practice these principles in all our affairs. Narcotics Anonymous, similar to Alcoholics Anonymous, was founded in 1953. Narcotics Anonymous groups also follow the 12 steps. They also have group meetings throughout the world, and its members choose a sponsor. The group members, however, consist of those who have abused drugs. Some patients may be a member of both Narcotics Anonymous and Alcoholics Anonymous. Monitoring client responses to the treatment plan and contributing to the revision of the plan of care as indicated. Nurses monitor client responses to treatments, and they contribute data that can be used for the revision of the plan of care as indicated. Coping mechanisms. Coping, simply defined, is the patient's ability to maintain and regain psychological homeostasis. Coping can be adaptive, and it can also be useless and maladaptive. Coping is adaptive when it resolves the stress, and it is maladaptive when it leads to more problems and it does not resolve the stress. Collecting data regarding the client's psychosocial functioning. Data and information that should be collected in respect to the client's psychosocial functioning should include the patient's specific psychosocial disorder, the patient's age at the onset of the disorder, the number of episodes that required intense treatment, the duration of these acute episodes, and the family's history of any psychiatric mental health disorders. Two standardized measurement tools that can be used to collect psychosocial data and information are the Range of Impaired Functioning tool and the Integrated Longitudinal Interval Follow-up Evaluation tool. The Range of Impaired Functioning tool measures the patient's level of functioning in terms of their work, their interpersonal relationships, their recreational activities, and the patient's levels of satisfaction. The Longitudinal Interval Follow-up Evaluation tool integrates into the Range of Impaired Functioning results. It measures the patient's progress over time in respect to their psychosocial functioning in terms of their work, their interpersonal relationships, their recreational activities, and the patient's levels of satisfaction. Identifying client support systems and available resources. Psychosocial support consists of individual, group, and family therapies, as well as the utilization of available community resources. Nurses should be knowledgeable about a wide number and variety of available resources so that they can recommend ones that the patient can benefit from and those that are also affordable and accessible to the patient. They should encourage the client to participate in several of these external support methods as appropriate to their need, and they should also educate family, friends, and whoever else is supporting the client about psychosocial functioning disorders and ways they can assist and support the affected patient. Identifying the client's use of effective and ineffective coping mechanisms. Coping strategies are perceptions, thoughts, behaviors, and emotions that a patient can use to cope with stress and any of their disruptions of psychosocial homeostasis. Stress is an important factor that greatly impacts on mental illness because it can worsen symptoms, it can lead to relapses, and it also impacts on all the other people who interact with the patient and who are not adversely affected directly with the psychiatric illness. Stress occurs as a result of significant life events such as illness, divorce, moving, parenthood, financial problems, and the death of a loved one. It also occurs as the result of the daily stressors that occur in normal life. Stress can affect the body in physical ways and in emotional or psychological ways. For example, stress can lead to anxiety, irritability, depression, a lack of focus, and forgetfulness. The physiological bodily responses to stress include headaches, sleeping impairments, trembling, stomach aches, muscular tension, and other somatic complaints. Some patients use a wide variety of coping mechanisms, and other patients may have few, if any, coping mechanisms. Coping mechanisms are learned. Some are effective, and others are not. Patients with no effective coping mechanisms must be taught about new and effective ways to cope with stress and stressors. Those who have effective methods of coping should be encouraged to use them during times of crisis. Commonly used coping mechanisms include changing one's perception of the issue at hand, using humor, using problem-solving skills, employing stress management and relaxation techniques, seeking out and using the support of others, ventilating feelings, embarking on a physical exercise and activity routine, decreasing personal expectations, and avoiding self-blame. Identifying stressors that may affect recovery, health, maintenance. Many factors, including stressors, affect a client's recovery from illness and their ability to maintain health. For example, lifestyle choices, bodily changes, and environmental factors that can affect a client's recovery from illness and their ability to maintain health. The Dimensions of Health model is helpful to remembering and understanding the factors that impact on the patient's recovery and health maintenance. The Dimensions of Health model consists of the biological, psychological, environmental, behavioral, sociocultural, and health systems-related factors that impact on the patient's recovery and health maintenance. The biological or biophysical factors, according to the Dimensions of Health model, include factors and forces such as the person's bodily changes, the person's genetics, and the person's level of functioning. The psychological factors that impact on the patient's recovery and health maintenance include the patient's level of stress and the effectiveness of their current coping mechanisms. Environmental factors that can influence health include the safety of the patient's environment, air pollution, home safety standards, and contaminated water. The behavioral factors that impact on the patient's recovery and health maintenance, according to the Dimensions of Health model, include things like lifestyle choices, such as the patient's exercise routine, their nutritional choices, and their consumption patterns relating to things like smoking, substance use and abuse, coffee drinking, and alcohol abuse. Sociocultural factors, according to the Dimensions of Health model, include things like the patient's available social supports, support systems, and cultural beliefs and practices. Health systems factors, according to the Dimensions of Health model, affect the patient's recovery and health maintenance because the accessibility, availability, and affordability of healthcare services for the patient may be contrary to health maintenance and recovery. Recognizing the abilities of the client to adapt to temporary and permanent role changes. Nurses must recognize and be able to address the client's ability to adapt to temporary and permanent life changes. Permanent role changes are often more stressful to the patient than temporary role changes because permanent role changes may cause major life changes and dependencies on others. Nurses can assist patients with their responses and reactions to permanent and temporary role changes by allowing and encouraging the patient to vent their feelings. They can also assist by helping the patient explore and identify realistic goals and to establish realistic expectations of what they are able to do despite some role changes and losses. Recognizing client responses to illness. Some of the most commonly occurring psychological and emotional alterations associated with illness include anger, denial, rationalization, grief and loss, fear, guilt, depression, suicidal and homicidal ideation, distress, loss of hope and meaning, and nearing death awareness. Anger can be turned outward, and it can also be turned inward and lead to depression. Anger turned outward can manifest with socially unacceptable hostility, physical violence, harm to others, and destructiveness. Anger can also be displaced to other more safe objects or people rather than the one who is the object of the person's anger. For example, a terminally ill patient may be extremely angry at the doctor, but they will not openly express that anger or act on the anger toward the doctor. Instead, they will direct their anger to the spouse, who is much safer than the doctor. Denial is a psychological defense mechanism. Denial occurs when the patient subconsciously ignores the existence of a threatening event or situation. Denial and rationalization, which is characterized with the patient's explaining away the threatening event or situation, is fully discussed later in this review with the topic, Recognizing the Client's Use of Defense Mechanisms. Grief and loss will be described and discussed in detail soon in this review with the topic, Grief and Loss. Depression, suicide, and homicidal ideation are fully discussed later with the topic, Identifying the Client Risk for Self-Injury and/or Violence. Fear, another patient response to illness, is characterized with feelings of dread as the response to an impending or actual danger, including psychological illness. Some of the signs and symptoms of fear that the patient can demonstrate are tachycardia, increased respiratory rate, hypertension, aggression, hostility, pupil dilation, vomiting, muscular tension, and feelings of dread, panic, and/or terror. Nurses address the needs of patients who are experiencing fear with a supportive environment, with the promotion of stress management and relaxation techniques, by assisting the patient to alter their perceptions of the threat and the severity of the threat, and by helping the patient to distinguish between real and imagined threats. Patients can also respond to illness with guilt. The ultimate purpose of guilt is to let the person know that they have done something wrong. The knowledge of and the recognition of guilt then allows the person to have the opportunity to change their unacceptable behaviors and to make amends for their transgressions and wrongdoings. Unresolved guilt, however, can lead to physical, psychological, and spiritual distress and despair. Nurses can help the patient to resolve their guilt by allowing the patient's free expressions of their feelings, by encouraging the patient to change their behaviors, and by encouraging them to make amends to others for their wrongdoings. Clients and family members may need psychological, spiritual, and religious support to resolve feelings of guilt. Distress can range along a continuum from mild to severe and even disabling. Distress can also be signaled with a number of signs and symptoms, some of which can be emotional, some of which are physical, and some of which are behavioral. The signs and symptoms of distress include headaches, dilated pupils, muscular tension, oral dryness, moodiness, depression, nightmares, forgetfulness, racing thoughts, frustration, irritability, rapid speech, nail biting, restlessness, and an inability to sit still or sleep. Again, relaxation techniques, counseling, and the support of family, friends, and nurses are used to help the patient overcome their distress. The loss of hope can have psychological, spiritual, and/or religious impact on the patient who is responding to their illness with this feeling. Some of the signs and symptoms associated with the loss of hope include apathy, withdrawal, a lack of motivation, spiritual distress, psychological distress, and a lack of involvement in the plan of care. Levels of awareness impact on how the nurse communicates with and cares for patients and their family members. The three types of awareness are open awareness, closed awareness, and mutual pretense. Open awareness occurs when the patient and family members know about the illness, impending death, and/or terminal illness. They are able to freely talk about it and discuss things like future plans and even the finalization of matters such as funeral arrangements. Closed awareness is defined as a complete lack of unawareness of the illness, impending death, and/or terminal illness. Lastly, mutual pretense occurs when the patient and family members are aware of the illness, impending death, and/or terminal illness, but they do not talk about it with each other. Open awareness facilitates full discussions and the freedom to express thoughts and feelings. Closed awareness and mutual pretense are isolating because they do not promote full discussions and the freedom to express thoughts and feelings. Open awareness can be facilitated with honesty, a trusting patient-nurse relationship, and the emotional support of the patients and family members who are impacted with the illness, impending death, and/or terminal illness. Providing support to the client with unexpected altered body image. Alterations and changes in the body image can occur predictably and expectedly along the developmental and maturational continuum of life. Alterations and changes in the body image can also occur unpredictably and unexpectedly as a result of illness and therapeutic treatments. For example, predictable and expected alterations and changes in the body image occur as a result of pregnancy, the normal deterioration changes associated with the aging process, and also as the result of the changes associated with puberty. Unpredictably and unexpected body image alterations as the result of illness and therapeutic treatments include changes such as alopecia secondary to chemotherapy, the loss of the breast as a result of breast cancer, the loss of functional ability secondary to paralysis, and the loss of the sexual body image with an orchiectomy secondary to testicular cancer. Patients with actual and perceived body image changes and alterations need the support of nurses and other members of the healthcare team in order to successfully cope with these losses. Using therapeutic techniques to assist the client with coping abilities. In addition to therapeutic communication and milieu therapy, nurses should promote the identification and utilization of more effective coping mechanisms. They should also establish boundaries that are necessary to achieve optimal outcomes. They must also promote relaxation and stress management techniques to assist the patient and their coping skills. Assisting the client to cope and adapt to stressful events and changes in health status. Some of life's most stressful events include acts of abuse, neglect, and violence, as well as highly significant life and physical changes that occur at the end of life and upon the diagnosis of a terminal disease and impending death. Abuse and neglect were previously discussed with abuse and neglect. Acts of violence such as suicide, homicide, and suicide-homicide will be discussed shortly with the topics collecting data on the client's potential for violence to self and others, and identifying the client risk of self-injury and/or violence. End-of-life care is also fully discussed later in this review under the topic End-of-Life Concepts. Assisting the client in maintaining their level of independence after unexpected bodily image. Patients who have been affected with an unexpected bodily change, such as paralysis or an amputation, need the psychological and physical support of the healthcare team to cope with these changes. For example, the patient affected with paralysis or an amputation can benefit from psychosocial healthcare services as well as the services of the rehabilitation and restorative healthcare team, such as those provided by a physical therapist, an occupational therapist, and a prosthetic expert. Monitoring the client's progress toward achieving an improved body image. With holistic physical and psychological care, patients who have an alteration of bodily image, such as can occur with a mastectomy, a colostomy, an amputation, a tracheostomy, or paralysis, can effectively cope with and adjust to this change of their body image. After the patient has effectively coped with the grief and loss, some of the signs that can indicate that the patient is progressing toward achieving an improved body image can include their visualization of and care for the affected bodily part, the resumption of their normal activities and interactions, and using assistive, enhancing prostheses like a breast form after a mastectomy and an artificial limb after a traumatic, unexpected amputation. Crisis intervention. A crisis is an acute but temporary episode, usually lasting from 4 to 6 weeks in duration, with which a client is subjected to an emotional reaction that their normal coping mechanisms may not manage. The components of crisis that make them so serious include an incident or event that has arisen without any warning or preparation, and the perception that this incident or event is highly serious and even life-threatening. These components of crisis often incapacitate patients. Crises can be classified as maturational, situational, and adventitious. Maturational crises include events such as retirement, pregnancy, and puberty. Examples of situational crises include the loss of the home to foreclosure, the loss of a spouse, and divorce. Examples of adventitious crises are the personal losses experienced as the result of Hurricane Katrina and a violent burglary in the patient's home. Identifying the client in crisis. The severity of a crisis can be categorized with levels of severity from 1 to 4. A 1 level of severity is the least disruptive of crises. A level 4 crisis is the worst of crises in terms of severity. The typical signs and symptoms experienced with the patient that can and should be identified by the nurse according to the level of severity for the crisis are as follows. Patients experiencing a level 1 crisis typically experience anxiety. They usually employ ego defense mechanisms that will be fully discussed later in this review course. Patients experiencing a level 2 crisis typically experience some loss of their ability to function. These patients may attempt to experiment with new and often ineffective ways of coping and increased anxiety because ego defense mechanisms are not effective enough to deal with this severe crisis. Patients experiencing a level 3 crisis are characterized with fight, flight, and panic. Those with a level 4 crisis will be completely overwhelmed, detached, disoriented, and even violent towards self and others. Identifying the client risk for self-injury and/or violence. Suicide, homicide, and suicide-homicide are severe psychological crises that must be prevented. The best way to prevent these adverse events is to prevent them by identifying patient risks and intervening to prevent these risks from transforming into these often deadly responses. For example, depression must be identified and treated so that it does not lead to suicide or suicide-homicide. The commonly occurring signs of suicide include saying goodbyes, a lack of interest in the future, guilt, shame, oral or written statements about suicide, changes in appearance, changes in personality, giving treasured possessions away to others, unusual behaviors, sleep alterations, and self-harming behaviors. Collecting data on the client's potential for violence to self and others. In addition to identifying a patient at risk by determining their risk factors, data and information is also collected in terms of the patient's intensity and duration of the depression, the elements of their suicide plan, their intensity of their suicidal intent, and an ongoing determination of the patient's current feelings about suicide and death until the risk has been eliminated and the patient is psychologically stabilized. All threats of suicide must be taken seriously and not minimized. The primary intervention is prevention. The environment of care must be open, supportive, honest, non-judgmental, caring, and filled with trust, compassion, and understanding. Constant observation and the use of restraints or seclusion may be necessary when the risk of suicide and self-harm are high. The safety of the suicidal person must be preserved and maintained. Homicide and suicide-homicide risk is also great among clients who are adversely affected with crises and depression. Some patients may decide on homicide or suicide-homicide because they are lashing out at those who they perceive caused their problems. Others may try to save others by killing them and keep them from the pain and suffering that the crisis brought to them. Still more, kill others and then promptly kill themselves to avoid further pain and suffering. Assisting in managing the care of the angry, agitated client. Information about managing the care of the angry, agitated behavior was previously discussed under behavioral management. Using crisis intervention techniques to assist the client in coping. In addition to maintaining the patient's safety, emotional and physical interventions are employed to assist patients with their coping and coping skills that are necessary to resolve the crisis. The first step is establishing trust and then allowing the patient to fully and freely ventilate their feelings in the therapeutic patient-nurse relationship. Nurses employ therapeutic communication. They remain respectful and caring. They give the patient feedback and guidance about coping skills. They encourage the patient's participation in one-to-one and group psychotherapeutic groups. They promote the client's use of alternative treatments such as meditation and guided imagery. At times, medications may be ordered and given to the patient on a temporary basis until the crisis is resolved. Providing opportunities for the client to understand why the crisis occurred. Nurses and other members of the healthcare team provide opportunities for the client to understand why the crisis occurred so they can gain some insight into it, how it occurred, and why it occurred, so they can gain a fuller understanding of how to prevent future occurrences. Guiding the client to resources for recovery from crisis. Client recovery and the prevention of future occurrences can be facilitated with follow-up care, information about crisis and coping skills, and with the use of local community resources as well as the maximization of social supports as based on the unique needs of the patient. Reinforcing client teaching on suicide, violence prevention. Teaching on suicide and violence prevention should include the signs and symptoms of crisis, the signs and symptoms of depression, the risk factors associated with suicide and violent acts, the importance of following the treatment plan, when to call for help, and who to call for help, including their doctor or a suicide prevention hotline. Reporting changes in client behavior. Nurses must be fully knowledgeable about the signs and symptoms of a possible impending crisis, so that they can immediately report patient changes to the charge nurse or supervisor so immediate attention to the client and interventions can begin. Cultural awareness. Similar to the widespread misinformation that spirituality and religion is the same thing, many also believe that ethnicity and culture is the same thing when they are not. An ethnic group shares a common characteristic, such as a language. Culture is a set of practices, customs, beliefs, and attitudes that is passed from generation to generation and not shared by others outside of the culture. Identifying the importance of client culture when planning, providing, monitoring care. Madeline Leiniger's theory of transcultural nursing is useful to nurses and the nursing profession in terms of understanding culture and how culture impacts on the care of the patient and the care of patient populations or groups. Madeline Leiniger's theory of transcultural nursing is quite popular in nursing. This theory supports the belief that nursing care for patients with a culture different from ours must be carried out using one or more of the following three nursing modes, which are 1. Cultural preservation and maintenance, 2. Cultural accommodation and/or cultural negotiation, and 3. Cultural restructuring and repatterning. During the assessment phase of the nursing process, the nurse determines the patient's cultural background, as well as their cultural beliefs, practices, preferences, and needs. The nurse then develops a plan of care that addresses and accommodates for these cultural beliefs, practices, preferences, and needs. Culture is very integral and central to patients, who they are, and what they do as a unique and valued individual. Culture greatly impacts on the client's health, the patient's needs, and their responses to care. Cultural competency allows nurses to gain insight into different cultures. It allows nurses to integrate cultural knowledge into the treatment of patients. It allows us to remain respectful of all humans and their cultural beliefs. It also gives us a deeper understanding of our patients and the importance of nurses' understanding of human beings as holistic beings. Recognizing client cultural practices that may affect interventions for procedures, surgery, and care. Culture impacts on all aspects of the patient-nurse relationship. Family dynamics, levels of self-efficacy, perceptions and views relating to health and illness, communication, space orientation, time orientation, and nutritional patterns are often driven by culture and cultural beliefs and practices. Now, we will discuss these beliefs and practices. Family dynamics. The roles of different members of the family, the size of the family, inter-family dynamics, interpersonal interactions, and communication patterns within the family unit often vary according to one's culture. For example, some families are paternalistic, with the male as the predominant figure of the family unit. Some families have top-to-bottom communication patterns, where the leaders communicate with the followers in the family unit and not from the bottom up. Some families value their elders, and others do not. Still, more culturally bound dynamics can include decisions and decision-making. For example, some families elicit the help of those outside the family in terms of decision-making. Others restrict decision-making to only one person, only the nuclear family members, or only the members of the extended family size in collaboration with the nuclear family. Self-efficacy. Simply defined, self-efficacy is the personal belief that they have the ability to do something successfully. Patients with the belief that they have self-efficacy will be motivated to learn. They will be motivated to participate in healthcare, and they will be motivated to change behaviors when they believe that they are able to do these things to promote health, prevent illness, and solve their current problems. Patients with low levels of self-efficacy believe that they cannot succeed, so they do not even try. Culturally, some cultural groups believe in and practice self-efficacy, and others do not. Perceptions relating to illness and health. Some cultures place a high value on health, health promotion, and wellness, and others do not. Some cultures believe that illness is stigmatic and outside of any control by the members of the culture. Still more may have culturally bound rituals and practices to promote health, to prevent illness, and to cure disease. Communication patterns. As fully discussed in the beginning of this review under the integrated process of communication and documentation, nonverbal and verbal communication elements such as vocabulary, terminology, silence, eye contact, facial expressions, and touch are influenced by and impacted with culture. Space and distance orientation. Space and distance orientation and tolerance also varies among cultures. It appears that cultures who live in crowded areas, such as in heavily populated urban areas, are more tolerant of closeness than those who have become accustomed to less crowded rural areas. Time orientation. Some cultures place more of a focus on one aspect of time more than the other two aspects of time. For example, some cultures focus more on the past than on the present or futures. Other cultures place an emphasis on the present rather than the past or future. Still more focus on the future rather than the past or present. Patients who focus on the future tend to be more committed to health, wellness, and prevention of future diseases, as well as solving the current healthcare problems in hopes of a better future. Nutritional patterns. Cultures differ vastly in terms of the meaning of food, preferred and favorite foods, cooking methods, and their rituals and practices relating to meals. For example, the Hispanic and Asian cultures prefer rice as a staple of their meal. Hindus, Sikhs, and Buddhists are vegetarians. Recognizing cultural issues that may impact on the client's understanding of and acceptance of psychiatric diagnosis. Cultural issues probably impact psychiatric patients and psychiatric diagnoses more than physical disorders. Culture may impact on the psychiatric mental health patient's willingness to seek out and use the professional services of the psychiatric mental health team. It may impact on the patient's and family members' perception of the psychiatric illness in terms of where it came from and whether or not the mental illness is imagined or real. Culture can also impact on how and where the patient verbalizes their inner thoughts and symptoms. Some cultures attach a social stigma to psychiatric disorders rather than viewing a psychiatric mental health as an illness in the same manner that physical diseases and disorders are. Making adjustments to care with the consideration of the client's spiritual and/or cultural beliefs. Nurses identify clients' spiritual and cultural beliefs in respect to mental health disorders and the treatments of psychiatric mental health disorders, after which they respect these cultural and spiritual beliefs and incorporate them into the patient's plan of care. Respecting the cultural background and practices of the client. To the greatest extent possible, nurses and other healthcare providers respect all patients by incorporating their cultural practices and rituals into the plan of care. Documenting how the client's language needs are met. As previously discussed, many clients have language needs that must be accommodated for in order to provide client care. Language and communication needs, such as those needs that require the use of a professional language interpreter, were fully discussed with the integrated process of communication and documentation. End-of-life concepts. Patients at the end of life and their family members have uniquely different needs than those who are experiencing other losses. Death, like all other life processes, can vary among individuals, but the process of death can also take on some predictable phases. Some people are at the end of life because of a relatively rapid but steady decline and deterioration over a short and brief period of time. Other people may decline and deteriorate gradually over a long period of time. Still more may be at the end of life and death with a very sudden and abrupt cessation of life as the result of some traumatic or physiological event, like an automobile accident or a myocardial infarction. The peri-death process consists of the first phase of the process, which is the preparation for death, the second phase of the process, which is the death itself, and the third phase of the process, which is the period of time immediately following the death. Some of the signs and symptoms that occur during the preparation for death include restlessness, incontinence, lethargy, social withdrawal, bodily coolness, respiratory changes, including Cheney-Stokes respirations, confusion, a lack of orientation to person, time, and place, a refusal to eat or drink, letting go, visual experiences and hallucinations, and saying goodbyes to loved ones. Identifying client end-of-life needs. End-of-life needs include physical, psychological, social and spiritual, cultural, and religious needs. Some of the physical needs at the end of life are anorexia, dehydration, and fluid and electrolyte imbalances. Patients in the peri-death process often experience a loss of appetite, anorexia, and weight loss. Intravenous fluids, total parenteral nutrition, and tube feedings can be used if the client chooses to have these treatments. When the client refuses these treatments, nurses and family members have to accept the patient's choice. Dehydration occurs when losses are greater than fluid gains. Fluid losses occur at the end of life as the result of symptoms such as vomiting and diarrhea. Fluid gains are often restricted and low when the patient is not eating and drinking, and also when they choose to forego artificial means of hydration and nutrition, such as intravenous fluid supplementation and tube feedings. Mild to moderate dehydration at the end of life can be manifested with dry skin, dry oral mucosa, constipation, a headache, thirst, orthostatic hypotension, dizziness, and diminished urinary output. The signs and symptoms of severe dehydration at the end of life are oliguria, anuria, sunken eyes, poor skin turgor, confusion, hypotension, tachycardia, tachypnea, fluid and electrolyte imbalances, fever, delirium, confusion, and unconsciousness. Simply stated, electrolytes and fluids are lost at the end of life as the result of dehydration and the lack of fluid and electrolyte replacements. More information about fluids and electrolytes and fluid and electrolyte imbalances is fully described in detail later in this review with fluid and electrolyte imbalances. Some of the psychological needs of patients and family members at the end of life include those relating to anger, hostility, anxiety, denial, depression, guilt, the loss of hope, the loss of meaning, sleep disturbances, the lack of intimacy, distress, confusion, fatigue, agitation, delirium, which will be fully discussed later in this review, financial fears, and fears of the unknown. The signs and symptoms of acute confusion include increased cognitive changes, agitation, hallucinations, restlessness, the lack of goal-directed behavior, and altered levels of conscious. The signs and symptoms of chronic confusion include impaired long-term and short-term memory, alterations in personality, altered responses to stimuli, impaired mental capacity, and the other signs and symptoms of acute confusion. Confusion resulting from psychological causes can typically be corrected with physical interventions. For example, confusion secondary to delirium can be corrected with the treatment of an underlying physiological disorder. Confusion secondary to hypoglycemia can be corrected with the administration of glucose or sugar. Fatigue, simply defined, is excessive tiredness that is often accompanied with a person's inability to perform their daily activities. Patients affected with severe fatigue may not even be able to do even minimal physical and mental work. Some of the factors that can lead to fatigue include physical weakness, stress, depression, and sleep deprivation, all of which can commonly occur among patients who are at the end of life. Fatigue at the end of life can manifest with lethargy, listlessness, a lack of motivation to do anything, guilt, and decreased levels of awareness and the ability to focus and concentrate on things like the basic activities of daily living. Some alternative treatment options for fatigue can include sleep promotion measures, stress and relaxation techniques, nutritional support, the correction of any biological causes that are leading to the fatigue, and psychosocial support. Clients who experience this agitation and restlessness at the end of life can manifest hallucinations, psychotic episodes, constant complaints, significant changes in behavior, and foul language that is not characteristic for the patient. Agitation and restlessness at the end of life can occur as the result of several causes, including fluid and electrolyte imbalances, decreased liver function, impaired renal functioning, and changes in terms of the acid-base or pH balance of the blood. When an underlying cause of agitation and restlessness can be treated, it is typically done. When the agitation is significant and not able to be corrected with the treatment of an underlying cause, anti-anxiety medications are often used. Some of the commonly occurring fears at the end of life include financial fears, fears of the unknown, fears relating to the loss of control, fears relating to the loss of a patient's independence, and fears relating to one's control over their own actions. At the end of life, many clients lose control over their physical, psychological, and social needs, and they also lose their independence. Nurses should facilitate and encourage as much independence and control as possible for the client, as based on their unique needs and capabilities. Roles and the ability of the person to perform their multiple roles also change at the end of life. The loss of role functioning, like the loss of independence, can lead to social isolation, depression, poor self-esteem, and despair. Identifying the client's ability to cope with end-of-life interventions. The ultimate goal of end-of-life care is to facilitate the client's and the family member's ability to effectively cope with the end of life and all the stressors associated with it. Patients and family members manifest effective coping when they are free of all psychological and emotional symptoms such as depression, agitation, fear, anger, and the other psychological and emotional symptoms at the end of life that were discussed above. providing care and support for the family and caregiver support at the end of life. Nurses and caregivers play a highly important role in the physical, psychological, and social support of the client at the end of life. Caregivers, however, need the support of the nurse to overcome their own fears about caregiving and to overcome the physical and psychological burdens of caregiving. Care of a loved one is often stressful and overwhelming. Caregivers need the support of the nurse. Respite care and other methods of social support can be helpful, as well as other interventions which are based on the caregiver's needs. Patients at the end of life have several essential comfort and dignity needs that should be addressed with measures such as the provision of comfort and privacy, maintaining the patient in a clean and dry condition, good oral hygiene, proper turning and positioning, and the continued determinations that indicate needs that can be met with comfort measures like massage, pain management medications, and the treatments of any other end-of-life symptoms. Assisting the client in the resolution of end-of-life issues. Death visuals vary among individuals, families, religions, cultures, and ethnic groups. For example, many families may want only members of the immediate nuclear family present and close to the loved one during their final hours. Some religious practices include a clergy person like a Catholic priest to perform that religion's sacrament of the sick. Some cultures, as well as some ethnic groups, may have special cultural death vigil practices and rituals at the end of life. Nurses accommodate for these vigils and the needs of all in attendance by providing simple measures such as the provision of comfortable and private seating, the provision of coffee or another drink of preference, and ongoing psychological and emotional support. After pronouncement, the client is then transported to the morgue or funeral home according to the planned final arrangements. If an autopsy is to be performed, the body should remain undisturbed, and things like tubes, lines, and catheters should not be removed. If, however, an autopsy will not be done, post-mortem care is done by the nurse. Grief and loss. Losses and feelings of grief can be actual, perceived, or anticipated. In other words, grief and loss can occur when the person has had an actual loss, like the loss of a beloved pet or death of a spouse. Grief and loss can also occur when the person has a perception of a loss that has not actually occurred, such as when they perceive that death is near when the patient's condition is not life-threatening or terminal in nature. Lastly, a patient can be affected with grief and loss when they anticipate a loss, such as that which can occur when a spouse is diagnosed with a terminal disease. Identifying the client's reaction to loss. There are some theories and models that relate to grief and loss. The most popular of these theories and models includes Engel's stages of grieving, Sanders' phases of bereavement, and Kubler-Ross's stages of grieving. According to Engel's stages of grieving, the stages of grieving in sequential order are 1. Shock and disbelief. 2. Developing awareness. 3. Restitution. 4. Resolving the loss. 5. Idealization. And 6. Outcome. Shock and disbelief are characterized with denial, a psychological defense mechanism that protects the person from overwhelming emotional responses that the person cannot yet cope with. When the person is ready to abandon the shock and disbelief, the person moves to a conscious awareness and acknowledgement of the loss. Then they resolve the loss with emotional responses that can even include anger and depression. Later, during the resolution stage, the client copes with the loss with a wide range of emotions and behaviors, including assuming a dependent role on others. Idealization is characterized with the grieving person's deification and idealization of the lost person, although at times, the grieving person may also have ambivalence and guilt. The outcome stage is marked with the resolution of the grief. The affected person is now able to resume their life as they knew it before the loss and the grieving process. Kubler-Ross's stages of grieving in sequential order are 1. Denial. 2. Anger. 3. Bargaining. 4. Depression. And 5. Acceptance. With the exception of bargaining, the other stages of grieving, according to Kubler-Ross, are self-explanatory. During the bargaining stage, the person attempts to avoid the loss by negotiating with others, including their God or higher power, to be able to do things such as the wedding of a daughter or the graduation of their grandson before they die. The phases of bereavement, according to Sanders' theory, in correct sequential order are 1. Shock, 2. Awareness of the loss, 3. Conservation and withdrawal, 4. Healing or the turning point, and then finally 5. Renewal. The shock phase of this theory is similar to Engel's stage of shock and disbelief and Kubler-Ross's denial stage. The awareness of the loss, according to Sander, is similar to Engel's stage of developing awareness. The person withdraws from others and experiences distress during the conservation and withdrawal phase. The healing phase is characterized with the person's attempt to resume their life. Finally, the renewal phase marks the resolution of the grief and loss. For example, during the conservation and withdrawal phase, the person will withdraw from others and attempt to restore their physical and emotional well-being. During the healing stage, the person will move from emotional distress to the point where they are able to learn how to live without the loved one. During the renewal phase, the person has resolved the grief, and the person is now able to resume their life as they knew it before the loss and the grieving process. Supporting the client in anticipatory grieving. As just mentioned, anticipatory grief occurs prior to the occurrence of an actual or perceived loss. The same interventions that will be discussed in a moment for patients experiencing all losses are also used for patients and family members affected with anticipatory grieving. Community peer support groups are also helpful to the patient and the members of the family unit when they are affected with anticipatory grieving. Reinforcing client teaching on expected client reactions to grief and loss. Patients must be knowledgeable about the grieving process, the expected and normal responses to a loss, and that grieving is a normal response to a loss. Grief includes physical, emotional, spiritual, social, and intellectual responses to losses. All losses have a potential impact on the patient. The amount of grief that a person experiences should, under normal circumstances, be proportionate to the severity of the loss. For example, the death of a pet goldfish should not lead to the same intensity of physical, emotional, spiritual, social, and intellectual responses as the loss of a grandparent does. The nurse assists the person with the grieving process by establishing trust, encouraging the person to vent their feelings, by encouraging effective coping strategies, by involving the family and significant others in the care of the client, and, when needed, referrals for additional emotional and spiritual or religious support. Providing the client with resources to adjust to loss, bereavement. In addition to establishing trust, encouraging the person to vent their feelings, encouraging effective coping strategies, and involving the family and significant others in the care of the client, patients are also to be supported when maladaptation, complicated grief, and excessive or prolonged sorrow are present and persistent. Some of the resources that may be helpful include psychological counseling, spiritual or religious counseling, and community support groups. The interventions for the management of complicated grieving include developing a trusting relationship with the client, the management of problems secondary to grieving, the facilitation of coping skills, and the utilization of all available support systems. Referrals to community resources, such as bereavement groups and internet bereavement groups, may also be helpful. Mental health concepts. Identifying expected behaviors of the client with an independent or dependent personality. Patients with an independent personality can be aggressive, addicted to work, antisocial, controlling of others, and egocentric without regard and without any respect for others. They may have difficulty having and maintaining interpersonal relationships. They may have approach avoidance conflicts. They may be exceedingly independent and view asking for the help of another as a sign of weakness. Patients with an independent personality fear failure. They typically expect perfection from themselves and others. Patients and people with a dependent personality lack confidence in their own judgments and decisions. Dependent people want others to make decisions for them because they believe that others, rather than themselves, are much better decision makers. These people are more prone to abuse by others than those with an independent personality. They can, at times, be adversely affected with feelings of apathy, feelings of helplessness, despair, depression, fears of rejection and abandonment, and substance abuse. Identifying client symptoms of acute or chronic mental illness. Now, we will discuss the signs symptoms, and treatment of several acute and chronic mental illnesses. Some of the most commonly encountered anxiety disorders include panic disorder, obsessive-compulsive disorder, generalized anxiety disorder, social anxiety disorder, and phobias. Anxiety can be classified as mild, moderate, severe, and at panic level. Some of the presenting characteristics of mild anxiety include irritability, mild agitation, restlessness, fidgeting, attention-seeking behaviors, and overall uneasiness. The signs of moderate anxiety can include trembling and shakiness, an increased pulse rate, an increased respiratory rate, memory loss, poor concentration, decreased attention span, muscular tension, a headache, backaches, and pacing about aimlessly. Severe anxiety is characterized with tachycardia, high blood pressure, feelings of impending doom, shortness of breath, confusion, rapid rambling speech, dizziness, nausea, and sleeplessness. The signs and symptoms that are associated with panic-level anxiety include chest pain, dilated pupils, immobility, feelings of absolute terror, hallucinations, delusions, pronounced severe hyperactivity, and possible physical exhaustion. Minor tranquilizers, cognitive behavioral therapy, stress management techniques, assertiveness training, and the development of more effective coping mechanisms are some of the interventions for patients with anxiety. Phobias manifest with overwhelming, illogical, and unreasonable fears of a completely harmless object or situation that poses little or no actual danger to the person affected with the phobia. Some patients with a phobia can become so limited in their daily life that it could be incapacitating to the person, their social relationships, and their travels. Phobias can be classified as specific, social, and agoraphobias. Specific phobias entail an object that is clearly identified by the patient as the trigger. For example, a person knows that they have an overwhelming fear of spiders or clowns. At times, the patient can have more than one specific phobia. Social phobias are characterized with intense fears and self-consciousness when the person is in a social situation like a group meeting. Agoraphobias can include both a fear of open spaces and a fear of closed spaces. For example, a person may have a phobia relating to standing in line in a crowd to enter a sports event. The signs and symptoms of phobias can vary in terms of intensity and severity. However, some of the general signs and symptoms include sweating, panic, intense anxiety, tachycardia, dyspnea, feelings of dread, and the avoidance of the stimulus that is causing the patient's overwhelming, illogical, and unreasonable fears. Post-traumatic stress disorder, or PTSD, is a condition that has an onset after a traumatic event like a gruesome murder or combat warfare. The signs and symptoms of post-traumatic stress disorder include physical and psychological symptoms, nightmares, intrusive and recurring memories of the event, memory problems, hopelessness, emotional numbness, irritability, anger, aggression, guilt, and a wide number of avoidances such as avoiding any discussion about the traumatic event, avoiding social interactions, and avoiding thinking about the precipitating traumatic event. Anorexia nervosa is marked with excessive food restriction and/or extreme physical exercise to prevent any weight gain. These factors can lead to complete emaciation and body wasting. Adolescents, young adults, gymnasts, and models are at greatest risk for anorexia nervosa. The signs and symptoms of anorexia nervosa include severe weight loss, fluid and electrolyte imbalances, muscle loss, purging behaviors, impaired personal relationships, a preoccupation with food and ways to avoid eating, secretive eating, irritability, anemia, brachycardia, amenorrhea, dental caries, impaired renal function, gastrointestinal tract erosion from the forced vomiting, and Russell's sign, which is calluses on the knuckles that result from the person's inducing vomiting with the fingers. Anorexia nervosa can be life-threatening when left untreated. Bulimia nervosa, another eating disorder, is characterized with eating binges that alternate with dieting or purging episodes. Purging can include vomiting, but also the excessive use of laxatives and cathartics. Patients with bulimia nervosa tend to be impulsive, extroverted, and sensitive to the feelings of others. The body weight may be normal or slightly overweight. Bipolar disorder is characterized with periods of excitation and elevated mood, referred to as the manic phase of this disorder, and periods of sadness and depression during the depressive phase of this disorder. The signs and symptoms of the depressive phase of bipolar disorder are depression, sadness, hopelessness, helplessness, restlessness, irritability, a loss of interest, poor concentration, suicidal thoughts, an inability to make decisions, and changes in the client's eating and sleeping patterns. The signs and symptoms associated with the manic phase of bipolar disorder are hyperactivity, an elevated mood, restlessness, insomnia, irritability, a loss of focus, rapid speech, racing thoughts, poor impulse control, impulsiveness, and risky behaviors. Depression leads to physical, emotional, and cognitive changes. The signs and symptoms of depression include feelings of hopelessness, feelings of helplessness, sadness, feelings of dejection, despair, sleep loss, poor problem-solving skills, diminished performance, listlessness, headache, weight loss, anorexia, social withdrawal, a loss of libido, crying, poor concentration, poor decision-making, personality changes, a lack of self-worth, and poor self-esteem. Personality disorders are defined as a pattern of psychological experiences and behaviors that are not congruent with society's norms and expectations. Some populations at risk for a personality disorder include victims of abuse, children from dysfunctional families, children of substance abusers, and children who grow up in cults or other extremist groups. The different types of personality disorders, their signs and symptoms will be discussed now. The paranoid personality disorder. Paranoid personality disorder is marked with an excessive and persistent distrust and suspiciousness of others, a failure to forgive others, uncontrollable anger, holding long-term grudges, and a need to maintain power and control in relationships. The obsessive-compulsive personality disorder. Obsessive-compulsive personality disorder is characterized with a preoccupation with control, orderliness, and perfection. For example, the person may be a compulsive hand washer. The borderline personality disorder. The patient affected with a borderline personality disorder can have a history of unstable relationships, fears of abandonment, impulsivity, a poor self-image, poor anger management, and persistent chronic feelings of emptiness. Schizophrenia affects the normal function of the brain in terms of the person's ability to feel, act, and think in an appropriate manner. The symptoms of schizophrenia include hallucinations, primarily hearing voices, a failure to differentiate between real perceptions and misconceptions, confused thought, delusions, and disordered speaking, which is often referred to as a word salad. Recognizing the client's use of defense mechanisms. Psychological defense mechanisms, also referred to as ego defense mechanisms, are subconscious mechanisms that protect the patient from extreme stress and anxiety that can arise from inner tensions and conflicts. Because these ego defense mechanisms protect the psychological integrity of the patient, these ego defense mechanisms should not be debated with the patient or stripped away by the nurse. The psychological defense mechanisms, their purposes, and some examples will be discussed now. Displacement. Displacement moves anger and hostility from one person or object to another person or object that has fewer repercussions. For example, a nurse who gets fired by the director of nursing decides not to punch the director of nursing, but instead, the nurse punches the office door. Projection. A person who is using projection will project and assign their failures and weaknesses on other people, the situation, or the environment rather than accepting the fact that the person is the cause of their own failure, weaknesses, and shortcomings. Projection allows the patient to protect their own self-image and self-esteem by placing blame on others and other things. For example, the aspiring nurse who fails out of nursing school will blame the nursing school and the nursing instructors rather than accept the fact that their lack of studying led to the failure. Reaction formation. A patient using reaction formation acts in a manner that is completely opposite of their true feelings. For example, the patient may intensely despise their spouse, but they act by supporting all the spouse's ideas and opinions in a loving manner. Repression. Repression pushes threatening thoughts deep down into the subconscious so that the person using repression is not aware of these thoughts or a stressful event until the person is able to effectively cope with it. An example of repression is when a person who is violently raped has complete amnesia about the rape. Regression. Regression brings a person back to a less threatening stage of development when they are threatened with extreme stress relating to the current time. For example, a 9-year-old child who wets the bed in the hospital during a severe illness is using regression back to infancy and toddler years. Sublimation. Sublimation is the replacement of a socially unacceptable feeling or urge with a socially acceptable urge or activity that substitutes for the unacceptable urge. This defense mechanism protects the person from acting in a socially unacceptable, impulsive manner and/or illegal manner. For example, a father with incestuous feelings and urges may become a highly active member of a church. Undoing. Undoing permits the patient to feel as though they have made up for and atoned for a wrongdoing. Undoing permits the person to avoid feeling guilty. For example, a wife may make her husband's favorite dinner after they have had a sexual relationship with another man earlier in the day. Compensation. Compensation protects the person's ego and self-esteem by overachieving in one area when they have failed in another. For example, the aspiring nurse who fails out of nursing school may decide to go to veterinarian tech school and overexcel in this school. Identification. The ego defense mechanism of identification permits the patient to avoid devaluing of self and to preserve their own self-worth by imitating the behaviors of the person they fear the most. For example, a girl who imitates her feared abusive mother's behavior is using identification. Minimization. Minimization involves the person's minimizing and decreasing the significance of a problem. For example, a diabetic client with severe leg ulcerations and/or lost eyesight may state that it is no big deal. Rationalization. Rationalization is used when the person attaches faulty logic and/or socially acceptable motives to behavior that is not socially acceptable or based on sound logic. Rationalization helps the person to cope with their lack of ability to meet standards and goals. A wife who pushes her husband may rationalize it by stating that her husband was not hurt. Introjection. Introjection, another ego defense mechanism, prevents the person from being shunned by society when the person accepts the values or beliefs of others, even when these values, beliefs, and norms are completely contrary to what they really believe. For example, an alcoholic may stop drinking and accept responsibility for destroying the family unit when they really do not feel this way. Intellectualization. Intellectualization is using rational thinking to explain some stress event or circumstance that was traumatic and stressful. Identification protects the person from psychological trauma and pain. An example of intellectualization can include a grieving spouse's belief that their deceased spouse just gave up, rather than accepting the fact that the spouse caused their own demise with poor lifestyle choices, like alcohol abuse. Recognizing changes in the client's mental status. Nurses must be skilled in the identification and recognition of changes in the client's mental status. Some of these changes in mental status can be sudden and dramatic, such as those changes that can occur with the rapid onset of delirium, and others may be much more subtle. Some of these changes can also gradually occur over time. Some ways to recognize and identify gradual changes in the patient's mental status can include the use of a standardized test tool like the mini mental status tests, and then comparing the client's current score with a prior baseline score. Some other possible signs of a changing mental status include restlessness, agitation, the onset of confusion, personality changes such as withdrawal, poor recall of information, memory loss, and changes in the person's level of activity. Recognizing client symptoms of a relapse. Many patients with a mental disorder, including substance abuse, have periods of relapse which can be quite disconcerting to the healthcare team. In addition to determining the cause of the relapse and addressing it, Nurses must also be knowledgeable about the signs and symptoms of a possible relapse. The signs and symptoms of a possible relapse can include neglected the filling of medication prescriptions, the worsening of symptoms, the development of complications, the emergence of abnormal laboratory test results, missed appointments, and multiple hospitalizations in a short period of time. Exploring why client is refusing or not following treatment plan. The fact that a client has an understanding of their treatment plan does not ensure compliance with it. Some of the factors that could lead to the patients refusing the treatment plan and not following the treatment plan can include socioeconomic hardship, the lack of health insurance, the inaccessibility of healthcare services, an altered mental or emotional state, and cultural, religious, and/or spiritual conflicts with the treatment and the treatment plan. Assisting in the care of a client experiencing sensory and perceptual alterations. At this time, we will discuss the care of the patient who is expecting a sensory or perceptual alteration, such as an auditory deficit, a vision deficit, sensory deprivation, and sensory overload. Depending on the gravity and extent of the patient's visual impairment, some possible interventions can include the nurses giving the patient their corrective lenses if they use one, use of large print materials with the patient, using the patient's name when coming into the proximity of the patient, identifying yourself when you come into close proximity with the patient, remain in the patient's field of vision when you are communicating with the patient, use of braille materials when appropriate, providing details about procedures before touching the visually impaired patient, informing the patient when you are exiting their room, and providing details about meals and the placement of all food items on the patient's meal tray or plate using the clock method. For example, the nurse may say, "Mr. A, your potatoes are at 3 o'clock on your plate." Depending on the gravity and extent of the patient's hearing impairment, some possible interventions can include the nurses giving the patient their hearing aid if they use one, always sitting while facing the patient when communicating with them, speaking slowly and enunciating words carefully. Shouting is not acceptable. Use of simple words, writing information and using printed material, minimizing all extraneous noises, and requesting an American Sign Language interpreter when indicated. Now it is time to discuss sensory deprivation and sensory overload. Sensory deprivation, which occurs when there is a lack of or deficiency of sensory stimulation, makes people more acutely aware of the few stimuli that are present in terms of sights and sounds. This heightened awareness leads to abnormal responses, such as hallucinations and delusions. Other signs and symptoms of sensory deprivation include apathy, a poor attention span, a lack of focus, sleepiness, depression, confusion, an impaired memory, and somatic complaints. Sensory deprivation can be prevented by providing the client with their assistive devices, such as eyeglasses and hearing aids, by providing devices and materials like a book or television which can stimulate the patient, by communicating with the client on a frequent basis, and by encouraging the client to participate in groups when possible. Sensory overload affects patients when there is far more stimulation in the environment than the patient can process and cope with. Some of the signs and symptoms of sensory overload include anxiety, muscular tension, sleep deprivation, fatigue, poor problem-solving skills, poor performance, restlessness, anxiety, and disordered, racing thoughts. Some of the ways that nurses can prevent sensory overload include the reduction or elimination of unnecessary stimuli such as noise and light, by controlling pain, by limiting visitors, by encouraging the patient to employ stress management techniques, by sticking to a routine schedule, and by slowly explaining things to the patient. Assisting in the care of the cognitively impaired client. Some of the things you can do while caring for a cognitively impaired patient will now be listed. Speak slowly and clearly. Keep conversations as brief and as short as possible. Give the patient enough time to fully comprehend and understand any information before continuing. Greet and call the client by name. Talk to the patient at their level, not over them. Maintain eye contact during communication. Use simple close-ended questions that only require a simple yes or no answer. Use nonverbal communication like hand gestures to further support the communication, and Empathize with the patient if they express or demonstrate frustration while attempting to communicate. Assisting in promoting client independence. Patient independence must be maintained and, when needed, restored to the highest possible level that the patient is able to be. Independence not only maintains the patient's functioning, it also maintains and enhances the patient's self-esteem and their integrity. There are many ways that nurses can promote independence among their patients. Ways with which the healthcare system can enhance and maintain independence include assistive devices like eyeglasses, hearing aids, walkers, and wheelchairs, the services of a physical therapist, an occupational therapist, and/or a speech therapist, and maintaining a safe environment within which the patient can safely perform activities without the risk of injury. Promoting the positive self-esteem of clients. Poor self-esteem can be chronic or situational. For example, a child may have temporary situational poor self-esteem after they accidentally wet their pants in kindergarten. An adult may have temporary situational poor self-esteem after they were laid off from their job until they find another one. An adolescent may have temporary situational poor self-esteem after their boyfriend broke up with them. Social and emotional support typically promotes positive self-esteem without any intense interventions. Patients with chronic low self-esteem, on the other hand, are affected with long-term poor self-esteem that may have resulted from some ongoing issues or from an accumulation of issues that are additive in nature. Patients affected with low self-esteem are passive, withdrawn, fearful of failure, overly sensitive to the negative feedback by others, they avoid eye contact, and they may have feelings of shame and guilt. Patients with impaired self-esteem can benefit from a number of interventions to promote positive self-esteem. Some of these interventions include praise when appropriate, helping the patient to set realistic and achievable goals, allowing the person to freely vent and express their feelings, and by showing the patient respect, understanding, and compassion. Religious and spiritual influences on health. Religions are formal institutions that are characterized with a formal set of practices, beliefs, principles, and values that a person with that religion believes in and follows in their daily life. Religions offer humans the ability to have a meaning and purpose in their life. Spirituality, on the other hand, is informal. Spirituality is without any formal set of practices, beliefs, principles, and values. Spirituality is, however, a way with which humans establish and maintain a holistic connectedness with others, the environment, and the universe. Many people who are spiritual believe in a higher power who is not necessarily God. Identifying client emotional problems related to religious and spiritual beliefs. Spiritual and religious needs often increase and become increasingly important when a person is affected with a physical and/or emotional illness, disorder, or disease. These needs are perhaps the most pronounced when the patient is affected with a terminal disease, such as cancer. In the vernacular, nurses care for the biopsycho, social, cultural, and spiritual, religious needs of patients. Some of the adverse emotional problems that can occur when the religious and/or spiritual needs of the patient are not cared for and addressed include spiritual or religious distress and a loss of meaning that transcends the everyday realities. Spiritual distress, which occurs when spiritual needs are not addressed, can result in emotional responses such as the loss of hope, the loss of meaning, the loss of a sense of purpose, feelings of abandonment, feelings that one is just lost, anger, and despair. Spiritual wellness and well-being, the opposite of spiritual distress, manifests with peace and calm, a sense of hope and meaning, and overall feelings of wellness. Patients with spiritual wellness can forgive others, they can express love, they have faith, they have hope, and they can transcend the here and now. Forgiveness is the spiritual belief that humans are far from perfect, and that all people make mistakes, and that all people are capable of transgressions. Humans can forgive others for their actions, and God can also forgive all people when the fallibility of human nature is understood. Recognizing the effect of the client religious and spiritual beliefs on the plan of care. Religious and spiritual beliefs and practices greatly impact on the plan of care. After these beliefs and practices are determined, the plan of care is modified and adjusted to accommodate for these patient needs. Some of the spiritual and religious beliefs, practices, values, and symbols that healthcare providers, including nurses, should be aware of are healing beliefs, such as prayers, formal religious healing ceremonies, spiritually based individual healing rituals, and other healing rituals like the Kuyarumi, which is used in Peru and incorporates the use of healing stones, are possible spiritual or religious healing beliefs that can and should be incorporated into the patient's plan of care. Muslims pray while facing Mecca, so their room should be accessible to a direction towards Mecca. Beliefs relating to birth, death, and the afterlife are also included in the plan of care according to the patient's religious or spiritual beliefs. For example, newborn Jewish babies have a Brit Milah, which is a ceremonious male circumcision performed by a rabbi. Catholics have the sacrament of the sick when a person is extremely ill. At the end of life, many religions have a strong belief of the afterlife in heaven, hell, and purgatory. Some religious dietary practices can include periods of fasting like on Good Friday among Catholics and on Yom Kippur among the members of the Jewish religion, meatless Fridays during Lent for Catholics, and a kosher diet for Jewish people. These religious dietary practices should also be incorporated into the patient's plan of care. Sacred symbols and readings which can be included into the plan of care can include a Muslim mullah, the Quran, the Bible, the Christian cross, and a Jewish menorah. Religious and spiritual beliefs relating to various treatments and procedures also impact on the patient's plan of care. For example, Catholics and other religions forbid elective abortions, and Jehovah's Witnesses are not permitted to receive a blood transfusion. Dress beliefs that can and should be accommodated for include things like a Jewish yarmulke and saris for a Hindu patient. Assisting the client to meet religious and spiritual needs. Nurses are also aware of the fact that they make referrals and accommodate pastoral support and visits with the clergy. Additionally, the clients should also be assisted to attend church or a synagogue when they desire to do so. Assisting in the evaluation of the client's religious and spiritual needs related to nursing interventions. As nurses provide care, they determine the patient's needs in reference to their personal religious and spiritual needs. Then nurses facilitate the fulfillment of these needs. For example, nurses provide opportunities for end-of-life religious and spiritual rituals, and they determine the patient's responses to these interventions. Respecting the client's religious and spiritual beliefs. Nurses respect all clients' beliefs, opinions, values, and practices, including those relating to the client's religious and spiritual beliefs, regardless of whether or not the nurse shares these same beliefs, opinions, values, and practices. Sensory and perceptual alterations. Identifying the needs of the client with altered sensory perception, delirium, and hallucinations. As previously discussed, the primary symptoms of delirium include fear, anger, anxiety, depression, restlessness, agitation, irritability, combative behavior, reduced awareness of the environment, decreased level of cognition, and hallucinations. Patients with delirium have a significantly altered sensory perception, which places them at risk for injuries, accidents, and emotional distress. Nurses must ensure the patient's safety and the patient's emotional comfort, in addition to the elimination of any possible triggers for adverse emotional and physical responses such as the lack of sleep, loud noises, and insufficient oral fluid intake secondary to delirium. Hallucinations are a serious concern for patients experiencing them. Safety is a priority of care. Verifying the client's ability to effectively communicate needs. All clients, including those with sensory and perceptual alterations, must be able to effectively communicate their needs to nurses and other members of the healthcare team. Alternative methods of communication must be considered. For example, the client may be able to communicate using pictures, and the nurse must be able to use behavioral signs like a grimace or a sad face to determine the client's needs. Stress management. Stress is a double-edged sword. Without stress, we would not even breathe or learn. For example, we breathe and take a breath when the psychological stressor of increased carbon dioxide is experienced by the person, and we are able to learn when we are motivated with a low degree of stress. In these respects, low and moderate amounts of stress are beneficial and essential to life. However, high levels of stress are physically and emotionally harmful. For example, high levels of stress, particularly when the high level of stress is also of long duration, can lead to distress, panic, hypertension, and other ill effects. For this reason, all humans, including patients, should be able to manage and control their stress before it takes control of them. Most hospitalized and ill patients have stress and anxiety. Stress and anxiety can be managed with non-pharmacological and pharmacological interventions. Some of the non-pharmacological interventions for stress and anxiety include meditation, prayer, deep breathing, progressive relaxation, distraction, imagery, and other techniques such as those that were previously detailed under the topic Assisting the Client in Using Behavioral Strategies to Decrease Anxiety. Identifying actual and potential stressors affecting clients. Physical, psychological, and environmental stressors can actually and potentially impact on the client and their families. For example, physical stressors include things like extreme environmental temperatures, a burn, and a medical emergency such as trauma or anaphylaxis. Some examples of psychological stressors, in addition to the stress and anxiety experienced with illness, can include the psychological abuse and neglect, the loss of a job, and financial jeopardy. Environmental stressors can include things like air pollution, contaminated water, and noise. Nurses identify stressors that are impacting on the patient, and then they plan care with interventions and strategies that can eliminate actual stressors and interventions and strategies to prevent the occurrence of potential stressors. Implementing measures to reduce environmental stressors. Healthcare facilities are filled with environmental stressors, such as noise and constant lighting, both of which interfere with a patient's comfort, rest, and sleep, and both of which can be prevented by nurses and other members of the nursing team. Community health nurses address and reduce air pollution and unclean water on a local, national, and global basis. Nurses in an acute care and long-term care facility identify and correct environmental stressors, such as noise and ambient temperatures, that interfere with the client's comfort and stress-free environment. Monitoring the client's effective use of stress management techniques. Nurses can monitor the client's effective use of stress management techniques in a number of different ways after teaching these techniques to the patient. For example, the nurse can directly observe the client's return demonstration of a stress management technique, such as deep breathing or guided imagery. Nurses can also determine whether or not the client's stress level has decreased with the patient's self-reports and the nurse's observations of the physical and behavioral signs of stress and anxiety. Determining the client's abilities to provide client support. Humans, as an interactive system, must be able to find and utilize support systems and social supports. Some patients are fully aware of and knowledgeable about the supports that they need and how to garner them. Other patients are in need of the assistance and help of a nurse to identify their needs, to find available supports, and how to use these necessary supports and support systems. Identifying the client's support systems and resources. Nurses identify and determine what client support systems and resources the patient is currently utilizing. After establishing this baseline relating to current supports, the nurse then determines whether or not these supports are appropriate for the patient and the patient's needs. They also determine what additional supports and resources can be tapped into to meet the patient's current needs. Identifying family responses to the client's illness. In keeping with the systems theory, the family and family members are affected in many ways when faced with an acute, chronic, or terminal illness that affects another member of the family. Family responses to illnesses vary according to the family, and they vary among different members of the family unit. The family dynamics, family and individual perceptions, past and present methods of coping, culture, spiritual religious beliefs, and severity and duration of the disease, the age of the person who is affected with the illness, and other factors impact on the responses of the family and its members in terms of the client's illness. For example, a severe chronic illness, with a prolonged duration places more stressors and stress on the family and its members than a short-lived acute illness that is not severe and is also one without any significant functional or role losses. Families and individual members of the family typically respond to acute episodes of an illness with low or moderate levels of stress and anxiety. Families and individual members of the family typically respond to chronic and severe illnesses with high levels of stress and anxiety. The most common reactions to illness include grief and loss as previously discussed, guilt, depression, a loss of hope and meaning, anger, denial, fears, financial concerns, sleep disturbances, poor coping, maladaptation, role changes, intimacy and relationship issues, and overall fatigue and anxiety. The signs and symptoms of anxiety include affective signs and symptoms such as fear, fright, helplessness, irritability, and worry. Behavioral signs and symptoms like vigilance, hypervigilance, and insomnia. Sympathetic nervous system signs and symptoms such as tachycardia, hypertension, and anorexia. Physiological signs and symptoms like trembling, muscular tightness, and diaphoresis. Parasympathetic nervous system signs and symptoms like weakness and fatigue. And lastly, cognitive signs and symptoms such as a lack of focus and attention, as well as poor problem-solving skills. Therapeutic communication. Providing emotional support to the client and the family. As discussed throughout this review course, nurses provide emotional support to the client and the family members in an ongoing manner within the professional and therapeutic nurse-patient relationship. Some of this emotional support is formal and complex, and other emotional supports are simple and informal. For example, individual and group psychotherapy is a formal and relatively complex form of emotional support, and a gentle, caring touch, as well as attentive, active listening, is relatively informal and simple. Assisting the client in communicating needs to healthcare staff. Patients may have difficulty communicating their needs to healthcare staff for a number of reasons. For example, some patients may not communicate their needs because they are too embarrassed to ask for help, or they do not want to bother others, such as a nurse. Still, more patients may have physical barriers to communication. For example, some patients may not be able to communicate their needs to the healthcare staff because they have a decreased level of consciousness, aphasia, or a cognitive disorder. Special methods of communication and modifications of communication must be used when the patient has a physical condition that impedes communication. Caring, compassion, and attentiveness to the patient and their needs helps to overcome emotional barriers to communication. Developing and maintaining therapeutic relationships with the client. The first step in developing a therapeutic relationship with a patient is the establishment of trust. Without trust, there can be no therapeutic relationship with a patient. Trust is developed with honesty, openness, caring, compassion, and respect. After trust is established, it must be maintained throughout the working stage or phase of the therapeutic relationship with the patient. The second stage of this therapeutic relationship is encouraging the patient to ventilate their feelings, fears, and anxieties. Other components of a therapeutic nurse-patient relationship and therapeutic communication are open and honest communication, the encouragement of the patient's expressions and venting of feelings, values, beliefs, and views, the provision of an environment that is unconditionally accepting and respectful, and the nurses maintaining a non-judgmental, unbiased attitude relating to the patient's views, feelings, and ideas of the client regardless of whether or not the nurse agrees with them. Using therapeutic communication techniques with the client. There are many factors that negatively or positively impact on the communication process, including attitudes, perceptions, emotions, cultural values and beliefs, roles and relationships, and environmental factors. Attitudes, both negative and positive, impact on communication. Perceptions impact on how a message is interpreted and processed by the receiver. Emotions such as fear, anger, anxiety, and pain impact negatively on the nurse-patient relationship and communication. Relationships and roles, as well as the patient's perceptions of these roles and the nurse-patient relationship, also affect communication. For example, clients may not freely communicate some information to the nurse and other members of the healthcare team because they perceive that the nurse is in a perceived position of power and that they are powerless. Environments that are conducive to communication and therapeutic relationships include privacy, physical and psychological comfort, trust, respect, and unhurriedness. Some of the most commonly occurring barriers to therapeutic communication are false reassurances, probing, changing the subject, defensiveness, disagreeing, judgments, and challenging. False reassurances increase patients' anxiety. They also lead the patient to believe that the nurse does not care about the patient and their thoughts. False reassurances include statements like, "Don't worry, you have a great doctor." Nurses may give false reassurance when the nurse is not able to cope effectively with the patient's thoughts and concerns. Nurses can prevent giving false reassurances by examining their own feelings and effectively coping with them during interactions with the patient. Probing can be described as an invasive violation of the patient's right to privacy when the nurse questions the patient about things that have no relevance to the nurse-patient relationship, but instead, these questions satisfy the needs of the nurse. For example, the nurse may probe the patient because they are curious about something. Humans, including nurses, change the subject inappropriately during a conversation when the person is just too uncomfortable to continue the discussion. Changing the subject is a conversation stopper. The patient may perceive that the nurse is changing the subject because the nurse does not care or is not at all interested in the patient and their needs. Again, the nurse must examine their feelings and overcome their tendency to want to change the subject. Defensiveness occurs when the nurse believes that they have to defend themselves and/or the healthcare facility that is providing care and services to the patient. The patient-nurse relationship revolves around the patient and their needs, not the nurse's needs. So, there is no need for the nurse to be defensive of themselves or the healthcare facility. The patient must be free to express and vent all of their feelings and thoughts. Disagreeing is another barrier to effective communication with patients. Like judgments, disagreements occur when the nurse and the patient have a difference of opinion. Again, it is the patient and the patient's beliefs and opinions that are valued and the most paramount. Therefore, there is no room for disagreements in the therapeutic nurse-patient relationship. Judgments force the patient to feel that they must agree with the nurse and change their own feelings, opinions, and beliefs. Nurses must communicate with patients without placing any value or judgments on the patient's personal beliefs and concerns. Challenging occurs when the nurse directly or indirectly asks the patient to justify, rationalize, and defend their personal beliefs, thoughts, and feelings. Challenging attacks the client and the validity of the patient's own thoughts and feelings. Respecting the client's personal values and beliefs. As repeatedly stated in this review, nurses must unconditionally respect and support the client's personal values and beliefs despite the fact that the patient's personal values and beliefs are not shared by the nurse. Establishing a trusting nurse-client relationship. As previously discussed, establishing trust is the first step of the nurse-client relationship. Using therapeutic communication techniques with the client. As fully discussed with the integrated process of communication and documentation under the title The Therapeutic Relationship and Therapeutic Communication, there are a variety of therapeutic communication techniques that should be employed during client communication. Some of these therapeutic communication techniques are attentive, active listening, silence, reflection, focusing, paraphrasing and restating, restating and paraphrasing, clarification, providing leads to the patient, and summarizing. Encouraging the client's appropriate use of verbal and nonverbal communication. Nurses should encourage patients to communicate with nursing staff using verbal and nonverbal communication. The nurse's caring presence and the nurse's willingness to spend time with the patient are probably the best ways to encourage patients to communicate with nurses and other members of the healthcare team. Monitoring the effectiveness of communications with the client. Communication, a dynamic interpersonal process, is considered effective and therapeutic when sent messages are fully comprehended by the receiver and when received messages are also fully comprehended. The therapeutic environment. Identifying external factors that may interfere with client recovery. Like all other healthcare-related issues, recovery is impacted by intrinsic and internal patient-related factors and also with extrinsic factors which are external to the patient. For example, physical recovery can be delayed and interrupted when the patient has diabetes. Physical recovery can be facilitated when the patient has family support. Similarly, psychological recovery can be enhanced when the patient has a strong support system. And psychological recovery can be impeded when the patient is not compliant with their medication regimen. Other factors that interfere with psychological recovery include disrupted family dynamics, the accessibility and affordability of healthcare resources, levels of stress, social stigma, and the lack of culturally competent care. Participating in community meetings. Psychological recovery is enhanced when patients and significant others participate in meetings within the healthcare facility and outside of it. For example, community meetings in the therapeutic healthcare environment can include such foci as socialization skills enhancement, self-care promotion, group psychotherapy, and psychological peer support. Community group meetings are available to also assist with psychological recovery. For example, disease-specific support groups like those for depression are available. Peer support groups like Alcoholics Anonymous and Narcotics Anonymous meetings are held 7 days a week in the patient's local community. Contributing to maintaining a safe and supportive environment for the client. Nurses contribute to establishing and maintaining a safe and supportive environment. Environments must be free of all physical safety hazards and also free of anything that could potentially jeopardize psychological safety. Physical safety, safety needs, and measures that must be taken to establish and maintain a safe physical environment free of hazards were thoroughly discussed within the safety section. Psychological safety is ensured with a consistently safe and supportive therapeutic milieu that meets the patient's needs. Monitoring the client's responses to environmental factors. Clients' responses to environmental factors vary among individuals. Some of these environmental factors lead to different patient responses depending on the patient's physical and psychological condition. For example, some patients can tolerate noise and continuous activity, and others do not. Some patients may become intolerant of a roommate when they have a fever or an acute illness after they have spent several days cohorting with the same roommate without any issues. Physiological integrity. The practical vocational nurse provides comfort and assistance in the performance of the activities of daily living. The practical vocational nurse must be able to institute bowel or bladder management, perform an irrigation of urinary catheter, bladder, wound, ear, nose, or eye. Provide for mobility needs, for example, ambulation, range of motion, transfer to chair, repositioning, or the use of adaptive equipment. Use measures to maintain or improve client skin integrity. Provide care to an immobilized client, for example, traction, splint, or brace. Assist in the care and comfort for a client with a visual and/or hearing impairment. Use alternative complementary therapy in providing client care, for example, music therapy. Provide non-pharmacological measures for pain relief, for example, imagery, massage, or repositioning. Evaluate pain using a rating scale. Provide feeding and/or care for client with enteral tubes. Monitor and provide for nutritional needs of client. Monitor client intake-output. Assist with activities of daily living. Assist in providing post-mortem care and providing measures to promote sleep rest. Basic care and comfort. Assistive devices. Assistive devices facilitate the performance of the activities of daily living, the maintenance and restoration of independence in terms of the patient's activities of daily living, the prevention of dependence on others, the prevention of complications such as those associated with immobility, and it also enhances the patient's feelings of self-esteem and self-worth. Assistive and adaptive devices are helpful to patients who need assistance with mobility and ambulation, as well as other self-care activities of daily living, such as bathing and grooming, which was discussed previously under the topic self-care. Identifying the appropriate use of assistive devices. Some of the commonly used assistive devices relating to mobility and ambulation include canes, walkers, crutches, wheelchairs, and prosthetic limbs. Crutches are typically used among relatively healthy and fit younger patients who have had an acute sprain, strain, or fracture. Crutches require arm strength to use them safely and properly. Many older people lack this necessary strength. A specific gait is ordered for a patient based on their physical condition. These gaits include the 2-point gait, the 3-point gait, the 4-point gait, the swing-through gait, and the swing-to gait. Patients are also fitted for crutches. The hands should be able to be firmly placed on the grips, and the armpits should not sustain any weight or pressure when the person is walking. All the weight is on the hands, which are on the hand grips. The patient's elbows should be slightly bent when holding the hand grips, and the hand grips should be even with the hip line. Canes can be a standard cane with 1 foot, a tripod cane with 3 feet, and a quad cane which has 4 feet. The length of the cane should be such that it only allows the patient's elbow to be slightly flexed. The cane is held in the hand on the same side of where support is needed. For example, the client will hold the cane with the left side when the left leg is affected. Walkers are indicated when the patient needs more support than a cane can offer. Walkers without wheels require that the patient is able to pick it up and move it forward. Other walkers have 2 wheels, and still more have 4 wheels with a seat and brakes. Although many patients prefer walkers with wheels, they can be unsafe and not fit for the patient when the patient is not able to control the walker without it rolling away. Walkers should be adjusted to a height that is level with the patient's wrist crease when they are standing erect. The patient's back should be erect and not hunched over when using a walker. Wheelchairs offer the greatest support in terms of the patient's mobility needs. Electric wheelchairs and scooters require some manual dexterity. Non-electric, manually powered wheelchairs require the upper arm strength of the patient or the assistance of another to push the wheelchair when the patient is unable to locomote and move the wheelchair on their own. The footrests of the wheelchair must be placed to the side before helping the client into the wheelchair. The brakes on both wheels of the chair must be locked during the patient transfers into the chair. When moving the client in the wheelchair, the feet must be on the footrests above the ground for safety. The rubber tips on a walker, cane, and crutches should be inspected often and immediately replaced if there is any sign of wear or bareness. Contributing to the care of the client using assistive devices. The therapist providing the assistive devices usually instructs the patient about its use, but nurses must also be familiar with the device so that they can assist the patient with the device and reinforce teaching when necessary. Some of these devices include feeding and eating devices like special utensils, plates, and drinking glasses, modified computers including voice-activated computers, telecommunication devices, touchpads, and communication boards. Reinforcing teaching for clients using assistive devices. Many people, including patients, do not always remember everything they are taught. Nurses, therefore, must observe patients and identify any techniques that are unsafe and performed incorrectly when the patient is using an assistive device. The nurse will then reinforce teaching related to identified learning needs in respect to their using an assistive device. Reviewing the correct use of assistive devices to clients and staff members. Nurses also review and observe staff members in their use of assistive devices, such as telecommunication devices, and then they reinforce teaching until the staff member or patient is competently using it. Elimination. Urinary and bowel elimination. Some of the commonly used terms relating to urinary and bowel elimination will be discussed now. Anuria is the lack of production of urine. Dysuria is painful burning upon urination. It often occurs as the result of a urinary tract infection or trauma. Oliguria is less than the normal amount of urinary output. The most commonly occurring causes of oliguria are impaired renal blood flow, renal disease, decreased fluid intake, and excessive fluid losses. Polyuria is an excessive amount of urine produced by the kidneys. Some commonly occurring causes of polyuria are diabetes mellitus and diabetes insipidus. Excessive and prolonged polyuria can cause dehydration. Urinary incontinence is the involuntary leakage of urine and a loss of bladder control. Urinary retention is the accumulation of urine in the bladder because, for one reason or another, the patient is not able to effectively empty their bladder. Constipation is less than 3 bowel movements per week. Diarrhea is a watery, loose stool. Fecal impaction is a collection of hardened stool in the rectum. Flatulence is gastrointestinal gas. Identifying the client at risk for impaired elimination. Some of the factors that place patients at risk for impaired elimination include some medications, some foods, an altered level of hydration, advanced age, weak muscular tone, the presence of some physical disorders, and psychological factors. There are a number of medications that can affect the body's normal urination and bowel elimination processes. Some medications can lead to the retention of fluids, increased urinary elimination, constipation and diarrhea, for example. High sodium salty foods impair and decrease urinary output and increase fluid retention. Some foods cause constipation, and other foods can cause diarrhea. Excessive hydration can lead to polyuria. Dehydration can lead to the scant urine and constipation. Older males can experience urinary retention and urinary incontinence because of an enlarged prostate gland. Older females can have urinary stress incontinence as the result of the loss of pelvic muscle tone secondary to having vaginal deliveries of babies. Both genders can be adversely affected with impaired sphincter control, which can lead to both bowel and bladder incontinence. Urinary function and urinary excretion can be affected by a variety of disorders, such as an anatomical defect, renal failure, hypertension, shock, vomiting, diarrhea, and other disorders. Bowel function and bowel elimination can also be affected by a variety of disorders, including an anatomical defect, infectious diarrhea, and other disorders such as ulcerative colitis and Crohn's disease. The lack of privacy, the lack of sufficient time to void or defecate, the lack of psychological comfort, and the need to use unusual devices such as a bedpan and/or urinal can impair normal urinary and bowel elimination for many people who are hospitalized. Instituting bowel and bladder management. Bladder and bowel management is a broad term that includes a number of different treatments and interventions. Some of these treatments and interventions include bladder training, bowel training, urinary catheterization, enema administration, and ostomy management. Bladder incontinence is more common among female patients rather than male patients. This increased frequency of urinary incontinence results from the female anatomy that has a shorter urethra than the male population, childbirth trauma that weakens the muscles of the pelvic floor, and menopause. Although females are more often affected than males, males can also be affected with bladder or urinary incontinence. Some of the factors that place males and females at risk for urinary incontinence, among other disorders, include poor pelvic muscle tone and strength, the lack of urinary sphincter control, urinary tract infections, injuries to the spinal cord, decreased levels of cognition and/or consciousness, and cerebrovascular accidents. Managing urinary incontinence includes bladder training, pelvic muscle exercises, maintaining skin integrity, and using external urinary drainage devices such as a condom catheter for male patients and briefs. Indwelling urinary catheters are strongly discouraged because they are a major source of hospital-acquired urinary tract infections, which can be very serious. Briefly described, bladder training entails the patient's practice in terms of resisting the sense of urgency, following timed voiding, and prompted voiding after the patient's urinary patterns have been determined. Common problems with fecal elimination include constipation, fecal impaction, diarrhea, bowel incontinence, and flatulence. When constipation cannot be prevented with interventions such as a high-fiber diet, exercise, and ample fluid intake, it may have to be managed with things like suppositories and enemas. There are 4 types of enemas: a cleansing enema, a retention enema, a carminative enema, and a return flow enema. The cleansing enema removes fecal matter that the patient is not able to expel. A cleansing enema is also used for preparation for surgery and for some diagnostic tests, such as a colonoscopy, so that the colon can be visualized without the presence of feces. A medication or an oil solution is instilled in the rectum and sigmoid colon with a retention enema. After installation, the contents of the enema are retained for at least 1 hour or more so that the hardened stool can be softened and more easily eliminated by the patient. A carminative enema is a fluid enema that is used to promote the patient's expelling flatus. A return flow enema is also used to expel flatus and also to decrease abdominal distension and pain, such as often occurs after surgery and general anesthesia. This type of enema is also referred to as a Harris flush. Fluid is instilled into the rectum and colon by the nurse who holds the enema bag of fluid above the patient's hips. After this fluid is instilled, the nurse lowers the fluid bag near the floor so flatus and the instilled fluid return to the bag. This installation and lowering the bag are done a number of times until the abdominal distension is dissipated and the patient is relieved of the pain and discomfort. A colostomy can be either permanent or temporary. Colostomies are done for a number of different reasons, including bowel rest, to bypass a bowel obstruction caused by a tumor, and to remove bowel contents when the distal colon and rectum have been surgically removed, as is often done when the patient has cancer. The different types of colostomies are an ascending colostomy, a transverse colostomy, a descending colostomy, and a sigmoid colostomy. The location of the stoma and the characteristics and composition of the stool depends on the type of colostomy that was done. Monitoring the client's bowel sounds. Bowel sounds are monitored in all 4 abdominal quadrants, which include the upper right quadrant, the upper left quadrant, the lower left quadrant, and the lower right quadrant. Bowel sounds are normally from 5 to 30 bowel sounds per minute. Bowel sounds can be decreased and even absent when the patient is affected with a bowel disorder, such as a paralytic ileus after surgery. Performing an irrigation of a urinary catheter and the bladder. When you perform an irrigation of a urinary catheter, you clamp the catheter between the injection port and the extension tubing. Clean the port with antiseptic wipes. Insert a syringe and slowly inject the irrigation solution. Remove the syringe, and then finally, remove the clamp and permit the irrigation solution to drain into the drainage bag. The procedure for bladder irrigation is as follows. Hang and prime the irrigation solution. Clamp all the clamps. Swab all ports with a disinfectant. Unclamp the irrigation clamp. Set the flow at the ordered and desired rate. Measure and document the volume of irrigating solution instilled, and then also measure and document the volume of urine in addition to the irrigating solution that is put out. Providing skin care to the client who is incontinent. In addition to keeping the incontinent client clean and dry, there are a number of topical agents used for the protection of the skin, including skin sealants that protect the skin from urine, stool, exudate, chemicals, dirt, and debris. Zinc oxide-based moisture barrier ointments that also protect the area, thick moisture barrier pastes that seal the area off and protect it from any moisture, solid skin barriers in the form of rings, strips or wafers that protect the skin in wounds, and skin barrier powders that are sprinkled lightly on the denuded skin to increase the sticking power of ointments, pastes, and solid skin adhesive barriers. Mobility, immobility. Immobility leads to severe complications and consequences in terms of virtually all bodily systems. Immobility leads to skin breakdown, pressure ulcers, and poor skin turgor. It can lead to contractures, muscular weakness, muscular atrophy, stiff and painful joints, and disuse, osteoporosis. The urinary system can be compromised with renal calculi, urinary stasis, urinary retention, urinary incontinence, and urinary tract infections. Respiratory system complications include atelectasis, pneumonia, and decreased respiratory vital capacity. Some of the cardiovascular and circulatory system complications associated with immobility include venous stasis, venous insufficiency, orthostatic hypotension, decreased cardiac reserve, edema, emboli, and thrombophlebitis. Immobility also leads to constipation and the loss of calcium from the bones as the result of the lack of weight-bearing activity during periods of immobility. Identifying the signs and symptoms of venous insufficiency and intervening to promote venous return. Additional risk factors, in addition to immobility, that can lead to impaired vascular perfusion and venous return include hypotension, decreased cardiac output, hypoxia, and immobilized limb, postoperative status, and diabetes. Compression anti-embolus stockings, elevation of the lower extremities, ambulation, intermittent sequential calf compression devices, and prophylactic anticoagulant therapy with a low molecular weight heparin or low-dose heparin are used to promote venous return and to prevent deep vein thrombosis and emboli. Providing for mobility needs. It is highly logical to understand why nurses must provide the patient's mobility needs, knowing how numerous and serious the hazards of immobility can be. The best way to prevent the body-wide hazards of immobility is to minimize immobility by providing for and assisting with patients' mobility needs. Encouraging ambulation and using needed assistive devices for ambulation, as discussed previously with self-care and assistive devices, is one way to provide for the patient's mobility needs. Other strategies include range of motion exercises and repositioning in a manner that maintains proper body alignment so the patient's ability to ambulate in the future is not impeded. Range of motion exercises can be active, active-assisted, and passive. Patients able to perform full joint movement on their own and without the assistance of another should be encouraged and monitored for their performance of full range of motion to all bodily joints several times a day. Nurses assist patients with range of motion exercises several times a day when patients are not completely independent in terms of their own performance of range of motion exercises. Passive range of motion is done by the nurse when the client is not able to even assist with range of motion exercise. Patients in a coma, for example, should be given complete passive range of motion to all joints several times a day by the nurse or a therapist. Some of the commonly used anatomically correct positions that are used by patients in bed are the Fowler's position, which is a sitting position with the head of the bed elevated, the dorsal recumbent position, and supine positions, which are laying on the back with or without a pillow for the head. The prone position on the stomach, the lateral position, which is a side-lying position with the uppermost knee bent and often maintained in that position with a pillow, and the Sims position, which is a semi-prone position. Reinforcing client teaching on methods to maintain mobility. Despite the fact that physical and occupational therapists assess and teach clients in terms of mobility measures such as preambulation exercises, active-passive range of motion, strengthening exercises, balance, gait, and isometric exercises, including those exercises that can and should be done in bed, nurses must not only reinforce this teaching, they must also remind the client to perform them and also assist them as needed. Using measures to maintain and improve the client's skin integrity. Pressure ulcers are a commonly occurring complication of mobility. Intrinsic and extrinsic factors and forces place patients at risk for impaired skin integrity. Some of the intrinsic factors that place clients at risk for pressure ulcers, in addition to immobility, are a poor nutritional status, cachexia and emaciation, hypotension, decreased cardiac output, poor tissue perfusion, hypoxia, bony prominences, any alterations of the fluid and electrolyte balances, aging, obesity, a condition that prohibits a client's free movement like paralysis, and some diseases and disorders such as diabetes, vascular deficiencies, and incontinence. Some of the extrinsic factors that place clients at risk for pressure ulcers, in addition to immobility, are radiation therapy, some medications, moisture, humidity, shearing, friction, and pressure. Interventions to maintain skin integrity and to prevent skin breakdown include the ongoing, continuous observation and monitoring of the client and their skin, keeping the patients dry when they are incontinent, turning and positioning clients at least every 2 hours, using special protective and preventive devices such as specialty beds and mattresses to prevent pressure, the avoidance of all friction, and encouraging mobility. Maintaining correct body alignment. Maintaining positions, such as the supine position that was just discussed, ensures correct bodily alignment. Assistive positioning devices such as pillows, wedges, and bolsters should be used to promote proper bodily alignment and to prevent harmful malalignment. Providing care to the immobilized client with traction, a splint, or a brace. Traction and other forms of immobilization, such as a brace or a splint, must be applied carefully and monitored frequently to ensure that the skin maintains its integrity, and to also ensure that the circulation is maintained and adequate, and, when traction is used, that the weights are as ordered and that they are freely hanging. Non-pharmacological comfort interventions. Identifying the client's needs for palliative and comfort care. Hospice and palliative nursing, scope and standards of practice, was developed by the Hospice and Palliative Nurses Association and ANA to further advance the practice of hospice and palliative care and to set benchmarks for all registered nurses and advanced practice registered nurses who practice nursing within the realm of life-limiting, progressive illness, or end-of-life care. The goal of hospice and palliative care nursing is to promote and improve the patient's quality of life through the relief of suffering along the course of illness, through the death of the patient, and into the bereavement period of the family. ANA and HPNA 2007, page 1. This specialty practice resource also focuses attention on educational preparation, advocacy and ethics, professionalism, collaboration, systems thinking, cultural competence, communication, and clinical judgment for hospice and palliative care nurses. Assisting in the care and comfort for a client with a visual and/or hearing impairment. As thoroughly discussed in the integrated process, communication and documentation, and in the section called Assisting in the Care of a Client Experiencing Sensory and Perceptual Alterations, nurses must facilitate communication and care with those who are affected with a visual or hearing impairment. The visually impaired patient, along the continuum of visual losses, after being supplied with their corrective lenses and eyeglasses, can benefit from large print materials and even braille materials. The hearing impaired, after being supplied with the corrective hearing aids, can benefit when the nurse faces the patient and speaks slowly during care and communication. Assisting in planning comfort interventions for the client with impaired comfort. Practical nurses collaborate with the registered nurse and other members of the healthcare team to plan a wide variety of comfort measures to meet the unique comfort needs of the client. Some of these comfort measures, among others, include the administration of pain medications, the application of heat and cold, the use of alternative and complementary comfort measures, and the use of other non-pharmacological measures. Applying therapies for comfort and the treatment of inflammation, swelling. Nurses promote comfort with the elevation of the affected limb above the level of the heart and the application of heat and cold applications. These measures decrease painful swelling that results from inflammation by dilating the vessels and constricting the vessels. Venous return and the prevention of swelling are accomplished with the elevation of a swollen limb. Heat constricts the vessels, and cold dilates the vessels. Vasodilation moves fluid and blood away from areas of inflammation. Vasoconstriction decreases the flow to the inflamed and injured area of the injury. These actions prevent and reduce swelling, inflammation, and muscle spasms. Both are used to reduce the pain and discomfort of inflammation and swelling. They can both be applied as a moist or dry application. Moist applications tend to be more effective than dry heat and cold. Cold applications are usually applied immediately after the injury and up to about 72 hours after it. Heat is usually used after 72 hours after the injury has passed. Because the use of heat or cold after 20 minutes reverses its effect, Heat and cold are applied and then removed after 20 minutes. Using alternative complementary therapy in providing client care and comfort. The number and variety of non-pharmacological interventions, including complementary, alternative, and integrative modalities, are numerous and varied. Some examples of alternative and complementary therapies that can provide the patient with comfort are meditation, prayer, magnets, chiropractic services, homeotherapy, Reiki, music, acupuncture, acupressure, massage, deep breathing, progressive muscular relaxation, distraction, guided imagery, biofeedback, hypnosis and self-hypnosis, mind-body exercises, and herbs and dietary supplements. Providing non-pharmacological measures for pain relief. In addition to these non-pharmacological alternative and complementary interventions, ways to promote comfort and decrease pain are positioning, repositioning, and the use of devices such as a transcutaneous nerve stimulation or TENS device. Providing palliative and comfort care interventions to the client. Nurses provide palliative care and comfort care interventions to address the physiological and psychological needs of patients at the end of life. Palliative care is distinctly different from medical curative care. Palliative care is given when the patient chooses to cease medical, curative treatments and to turn the attention of and the focus of care from cure to physical and psychological comfort. Some of the commonly occurring physiological disorders that affect clients at the end of life and the related nursing care will be discussed now. Hypercalcemia, which affects many oncology patients, can lead to nausea, vomiting, bone pain, and abdominal pain. Nurses must manage this pain and also ensure the patient's safety because bone fractures can occur. Hemorrhage and shock can lead to extreme fear and anxiety. Septic shock can lead to respiratory distress and pulmonary edema. Tumor lysis syndrome can cause nausea, vomiting, abdominal pain, and flank pain. Spinal cord compression can lead to back and leg pain. Superior vena cava syndrome is often accompanied with symptoms such as respiratory distress and hypoxia-related air hunger, which disrupts the patient's levels of psychological comfort. Pneumonitis can be accompanied with shortness of breath and respiratory distress. Malabsorption syndrome can cause abdominal pain and disconcerting explosive diarrhea. End-of-life respiratory gurgling can be distressing to family members, so repositioning the patient may be helpful to correct this physiological change at the end of life. The syndrome of inappropriate antidiuretic hormone often leads to changes in the patient's mental status, irritability, and other mood swings. The commonly occurring cognitive and psychological disorders that affect clients at the end of life and the related nursing care will now be discussed. Sometimes, reversible delirium leads to decreased cognitive functioning and behavioral changes that can result from the patient's hallucinations, fear, anger, anxiety, agitation, and irritability. And irreversible dementia can also lead to the same alterations of cognitive function and behaviors as dementia. The most commonly occurring emotional and psychological responses to illness that impairs the patient's psychological comfort are anger, hostility, anxiety, death anxiety, feelings of helplessness, irritability, fright, denial, depression, fear, loss of hope and meaning, distress, dread, panic, relief, guilt, insomnia, and other sleep disturbances. In terms of psychological changes at the end of life for both the patient and their significant others, interventions focus on the management of these changes in terms of a therapeutic environment, allowing and encouraging the patient and others to vent their feelings. Non-pharmacological psychological interventions such as psychological counseling and, when indicated, medications such as antidepressants. In terms of the physiological changes at the end of life, physiological interventions often include the treatment of the symptoms that result from the physiological disorder rather than treating the underlying cause. For example, the underlying cause of hypercalcemia may not be treated, but the symptoms of pain and the patient's compromised level of safety may be addressed. Pain management is a common intervention to address the physiological disorders at the end of life. Respecting the client's palliative care choices. Nurses provide palliative and comfort, physical, psychological, social, and spiritual religious care to the client who is receiving palliative care. Nurses respect and support the client's palliative care choices despite their own personal beliefs and opinions. Reinforcing client teaching on stress management techniques. Nurses identify the need for a client to perform stress management techniques, including progressive relaxation, exercise, meditation, and imagery. They also reinforce client teaching in respect to the proper use of these techniques. Reinforcing client teaching on palliative comfort care. Nurses reinforce teaching relating to palliative and comfort care as often as needed. Some of the primary areas of teaching include the signs and symptoms of imminent death, the progression of the death and illness progression, pain, the impact of pain, and pain management plans. Patients and significant others must be knowledgeable about the signs and symptoms of imminent death so that the psychological consequences of not knowing, such as fear, stress, distress, and panic, can be prevented. Some of the signs and symptoms of imminent death that the patient should be knowledgeable about are respiratory changes, such as Cheney-Stokes respirations, a refusal to eat or drink, decreasing levels of consciousness, bodily coolness, fecal and urinary incontinence, confusion, restlessness, and social withdrawal. They must also be knowledgeable about the normal and expected progression of the patient's specific illness or illnesses and the peri-death process in order to allay fears and to promote coping when these changes are expected and anticipated. Pain and the plan of care in place for the patient should also be reported and reinforced with the patient and significant others. Fears of pain and pain itself significantly decrease the patient's level of comfort, their degree of involvement in the plan of care, their interactions with others, and it shatters the remaining quality of life. Patients and significant others must know about the pharmacological and non-pharmacologic pain management interventions that will be used. Patients and significant others must also know how and when to report their pain. Monitoring the client's nonverbal signs of pain and discomfort. Some of the nonverbal signs of pain and discomfort can include guarding, grimacing, crying, and calling out in pain. Monitoring client response to non-pharmacological interventions. Nurses monitor the client's responses to non-pharmacological interventions in terms of the client's level of comfort. As with pharmacological interventions, non-pharmacological interventions have expected outcomes like a reported or observed decrease in the levels of pain and discomfort and increased levels of comfort as reported by the patient or observed by the nurse. Monitoring the outcome of palliative care interventions. The expected outcomes of palliative care interventions are numerous. For example, expected outcomes include both the client's and the family member's decreased stress and anxiety and increased levels of comfort and communication. Evaluating pain using a rating scale. Based on scientific evidence that people of all ages, from neonate to the elderly, and people in all states of consciousness and unconsciousness experience pain, all human beings, young and old, conscious and unconscious, must be evaluated for the presence of pain so that effective interventions can be planned and implemented for the patient in pain. As just discussed, there are a number of pediatric pain scales that can be used for this population to evaluate pain. Most of these scales and tools are standardized tests for behaviors that indicate pain, such as grimacing and crying. Others, like FACES scale, are basic standardized tools that can be used among children who have developed some insight into their pain and the related emotions, such as sadness, which occur as the result of pain. As the child further develops and can communicate in a more refined manner, numerical rating scales for pain from number 1 to number 10 in terms of pain intensity can be used. A numerical rating scale for pain is also used among adults, but, at times, A FACES type scale is used when the patient is not able to communicate details about their pain for one reason or another. Nutrition and oral hydration. Adequate nutrition consists of the ingestion and utilization of water, essential nutrients, vitamins, and minerals to maintain and sustain health and wellness. A normal diet should consist of all of the food groups including fruits, vegetables, dairy foods, protein, and grains according to the United States Department of Agriculture. Like other basic human needs such as elimination, nutrition can be negatively impacted by a number of factors and forces such as diseases and disorders like anorexia, nausea, vomiting, dysphagia and malabsorption, cultural and ethical beliefs about nutrition and foods, personal preferences, level of development, lifestyle choices, economic restraints, psychological factors and disorders such as eating disorders, medications, and some treatments like radiation therapy and chemotherapy. Identifying the client's potential for aspiration. A number of client factors and treatment factors place the client at risk for aspiration. Some of these factors include sedation, decreased gastrointestinal motility, vomiting, the presence of a feeding tube, a tracheostomy tube, and/or an endotracheal tube, dysphagia and other swallowing disorders, an impaired or absent gag and cough reflex, and a diminished level of consciousness. Preventive measures, such as keeping the patient up at a 30-degree angle, must be implemented to prevent life-threatening aspiration. Checking the client feeding tube placement and patency. Nasogastric tube patency and placement are determined and confirmed at least every 4 hours with continuous tube feedings and before each feeding when intermittent tube feedings are being given. Tube placement is determined by a number of different methods and techniques, including testing the aspirated contents for pH and checking the initial placement with a radiographic examination. After initial placement is checked and confirmed, ongoing monitoring of tube placement and patency are done by aspirating and checking the aspirate for pH with a pH of more than 6, which is an indication that the tube may be in the respiratory tract rather than the stomach, and/or testing the aspirate for bilirubin when it is possible that the tube is present in the intestine or the lung when these findings are not normal for the stomach, which is normally from 1 to 5, and/or by checking the radiopaque tube placement with radiography, and/or by osculating the epigastric area with a stethoscope to hear air sounds when about 30 milliliters of air are injected into the feeding tube. Providing feeding and/or care for the client with enteral tubes. Enteral nutrition provides liquid nutrients and necessary nourishment to patients with a gastrostomy or nasogastric tube. The components of these solutions include calories, fats, carbohydrates, and proteins, and tube feedings can be delivered to a patient on a continuous or on an intermittent basis. The complications associated with enteral feedings include aspiration, inadvertent improper placement, inadvertent tube dislodgement, leakage and/or irritation at the insertion site, diarrhea, constipation, nausea, vomiting, and an occasional foodborne illness that may result from contaminated enteral nutrition solutions. In addition to monitoring the patient for the complications of enteral feedings, the nurse should also clean the nostril and tube using a benzoin swab stick, applying a water-soluble lubricating jelly just inside the nostril to prevent dryness and soreness, providing frequent mouth care, and replacing the securing tape as often as necessary. In terms of maintaining tube patency, nurses check and measure residual about every 4 to 6 hours. They irrigate the tube with about 15 to 30 milliliters of warm water before and after each intermittent feeding and at least every 4 hours when continuous feedings are being given. And they maintain the head of the bed up at least 30 degrees during feedings and at least 1/2 hour after feedings. No feedings are given when the tube is not properly placed, or when the residual volume is excessive and/or the tube is not patent. The doctor is notified with these occurrences. Additionally, nurses can decrease the rate of feeding when gastrointestinal complications such as diarrhea, constipation, or abdominal cramping and pain occur. Monitoring and providing for the nutritional needs of the client. As previously discussed somewhat, nutritional needs differ among the age groups during the lifespan. The age groups and the maturational events that are most often associated with variation in nutritional needs are infancy, childhood, adolescence, older adulthood, and during menopause, lactation, and pregnancy. Nutritional needs also vary according to the physical status of the client. For example, nutritional needs change and the forms of the diet and nutrition vary when a patient is affected with a disorder such as diabetes or a swallowing disorder. Therapeutic diets are used for patients with specific nutritional needs and restrictions. Some of the most commonly used therapeutic diets include a clear fluids diet, a full fluids diet, a pureed diet, a mechanical soft diet, and a low-fiber diet. All clear fluids, including tea, clear broth, water, ginger ale, clear Italian ice, hard candy, and gelatin are permitted with a clear fluids diet. Milk, fruit and vegetable juices, eggs, ice cream, strained cereals, and puddings are included with a full fluids diet. A pureed diet consists of foods at different consistencies according to the patient's needs that are pureed with a blender. A mechanical soft diet consists of ground meat, soft fruits, vegetables, cereal, bread, soft cake, fish, eggs, and poultry. A low-fiber diet consists of easily digested foods with low fiber and little seasoning. Monitoring the client's ability to eat. A patient's ability to eat can be adversely affected with things like an inability to chew, an inability to swallow, inadequate or absent teeth, psychological impairments, altered levels of consciousness, and other physical and medical problems such as nausea, vomiting, and anorexia. Monitoring the impact of disease, illness on the client's nutritional status. Many diseases and illnesses impact the client's nutritional status. For example, psychological eating disorders like anorexia nervosa and bulimia nervosa can lead to malnutrition and underweightness. Disorders that affect the central nervous system can impair nutrition when the levels of consciousness is decreased or the patient is confused and uncooperative. Fevers cause malaise and nausea. Gastrointestinal diseases and disorders such as vomiting, diarrhea, malabsorption, failure to thrive, cancer of the stomach, colorectal cancer, cancer of the esophagus, hepatic cancer, and cancer of the pancreas also adversely affect the patient's nutritional status. Monitoring the client's intake and output. Intake includes all foods and fluids that enter the patient's mouth or internal bodily cavity. For example, consumed ground beef, clear fluids, intravenous fluids, and enteral feedings are considered intake. Output is all fluids and eliminated wastes that leave the body. For example, feces, emesis, and urine are forms of output. Solid intake is monitored and measured in terms of ounces. Liquid intake is monitored and measured in terms of mLs or cc's. Solid output is monitored and measured in terms of the number of bowel movements. Liquid stool is monitored and measured in terms of mLs or cc's. Urinary output is monitored and measured in terms of mLs or cc's for toilet-trained adults and children, and in terms of a diaper count for neonates and infants. Emesis is monitored and measured in terms of mLs or cc's. A urinary output of less than 30 mLs or cc's per hour is considered abnormal. Indirect evidence of intake and output can be determined with the patient's vital signs, the signs and symptoms of fluid excesses and fluid deficits, weight gain and losses that occur in short term, laboratory blood values and other signs and symptoms such as poor skin turgor, sunken eyeballs, and orthostatic hypotension. Reinforcing client teaching on special diets based upon client diagnosis, nutritional needs, and cultural considerations. Individuals and cultures vary in terms of their food preferences. Adherence to dietary restrictions and therapeutic diets is challenging to most clients. As much as possible, nurses should accommodate for the client's cultural and personal preferences and reinforcing teaching regarding these dietary treatments. Promoting client independence in eating. Patients should be encouraged to maintain as much independence as possible when it comes to eating and dietary choices. At times, assistive devices such as special utensils and weighted plates and verbal cueing can be effective in terms of establishing and maintaining independence in terms of eating. Personal hygiene. Personal hygiene includes bathing and washing, foot care, hair care, nail care, perineal care, shaving, mouth and oral care, and denture care. Determining the client's usual personal hygiene habits. There are a variety of different factors that influence hygienic practices. They include culture, religion, environment, developmental level, level of energy, and personal preferences. Cultures and cultural practices relating to hygiene vary around the globe. In North America, for example, there is a high cultural value on cleanliness, daily bathing, an odor-free body, and the absence of leg hair on females. Other cultures, however, may only bathe once a week or less, and they are not offended with bodily odors or the presence of underarm and leg hair among females. Some religions have religious ceremonial bathings and washings, and other religions may have no impact on hygiene practices. The patient's environment also impacts on hygiene and hygiene practices. For example, patients, such as the homeless and those in third world countries, have no running water. Level of development also impacts on hygiene. For example, neonates are bathed and provided with all their hygiene by the parents, and adults are typically independent in their hygiene self-care. Acutely and chronically ill patients often lose independence in terms of their hygiene and hygiene practices because they lack the energy and strength to perform hygiene. Lastly, personal preferences impact on hygiene and hygiene practices. Some prefer to shower in the morning, and some prefer to shower at night before going to bed, for example. Nurses identify and accommodate for the patient's strengths and weaknesses, cultural and religious practices, and personal preferences whenever possible to plan hygiene care that specifically meets the needs of the patient. Assisting with the activities of daily living, hygiene. In the healthcare setting, there are 3 different types of baths that clients have available to them. They are a complete bath, a partial bath, and a tub or shower bath. With all types of baths, the water temperature must be checked to ensure that it is safe and less than 110 degrees to prevent scalding and burns. A shower chair, tub chair, grab bars, and non-skid bath or shower mats are highly important to prevent accidents. Clients may prefer to shower over baths. Clients may need assistance getting in and out of the shower and tub when a bed bath is not given. Perineal care, like bathing of the skin, prevents infections, odors, and irritation of that area. Perineal care is done with a bed bath, shower, or tub bath. Perineal care is done more often for patients affected with incontinence and diaphoresis, for example. Special perineal care is given to patients with an indwelling urinary catheter. Male clients often want a facial shave once a day or once every couple of days. Female patients usually want their underarms and legs shaved about once a week. Shaving for patients is often not risky, except when the patient is taking an anticoagulant blood thinner. This places them at risk for nicks and bleeding. Oral hygiene is done at least twice a day and more often is needed. Oral hygiene consists of brushing the teeth, flossing the teeth, and rinsing the mouth. Partial and full dentures are also brushed and rinsed. Feet are washed with the bath and more often as needed. Diabetics and other patients at risk for infections should get special foot and toenail care and monitoring. For example, the feet must be completely cleaned and dried and examined daily for any signs of skin breakdown, corns, bleeding, broken, chipped, or absent nails, as well as blue or pale nail beds. Patients' hair can be washed with shampoo and conditioner in the shower, bathtub, and in bed with a special bed tray or dry shampoo. Patients should also be encouraged to comb or brush their hair a couple of times a day. Client nail care is another important area of hygiene. Clients' nails need to be checked daily to observe them for any irregularities. The client's nails should appear clean because dirt can cause infection. The client's nails should be trimmed short and smooth, as jagged nails have the ability of causing injuries to the client or to the staff attending to them. Assisting in providing post-mortem care. Standard precautions are maintained after a patient's death when providing post-mortem care. Post-mortem care consists of washing and drying the patient's entire body and removing all medical equipment, such as indwelling urinary catheters and intravenous lines. The deceased patient's hands and legs are gently placed in good alignment. The eyes and the jaw are held closed, and the body is then wrapped in a shroud after an identification tag has been placed on the client's greater toe and on the outside of the shroud prior to transfer to the morgue. Reinforcing teaching to the client on required adaptations for performing activities of daily living hygiene. Clients in need of assistive devices and other adaptations to ensure safety and/or maximum independence should be instructed on their proper use and reminded to use them consistently. Some of these devices and adaptations include shower chairs, grab rails, handrails, back sponges, and special tools for nail care. Rest and sleep. Good sleep habits and rest promote health and well-being in people. The sleep cycle consists of several stages of varying duration and characteristics. The stages of the sleep cycle are non-rapid eye movement stage 1, non-rapid eye movement stage 2, non-rapid eye movement stage 3, non-rapid eye movement stage 4, and the stage of rapid eye movement, which is often referred to as REM. The duration of sleep that is needed to promote and maintain health varies among the age groups. For example, newborns sleep 14 to 17 hours per day. Infants require 12 to 15 hours of sleep each day. The toddler needs 11 to 14 hours. Preschool children require 10 to 13 hours of sleep per day. School-age children need 9 to 11 hours of sleep. Adolescents require 8 to 10 hours of sleep every day. Adults need 7 to 9 hours, and older adults can get only 7 to 8 hours of sleep each day to maintain health. Many factors can impact on the quality and duration of a person's sleep. Some of the factors that impact on sleep include illnesses, the presence of pain, the presence of stress and anxiety, the environment, poor lifestyle choices like consuming coffee and alcohol before sleep, cigarette smoking, and some medications such as steroids and antidepressants. Commonly occurring sleep disorders are insomnia, which can include difficulties falling asleep and/or staying asleep, hypersomnia, which is sleeping too much and not being able to stay awake, parasomnias, which are things like sleepwalking and sleep talking, narcolepsy, which is the abrupt sudden falling asleep during daytime hours, and sleep apnea, which can be categorized as obstructive sleep apnea, central sleep apnea, and combined sleep apnea, which is the combination of both obstructive and central sleep apnea. The most common treatment for sleep apnea is the use of a CPAP machine during sleeping hours. Identifying the client's usual rest and sleep patterns. Hospitalized patients often experience sleep problems that result from a number of factors, including their medications, pain, anxiety, and a noisy, unfamiliar environment. As often as possible, nurses should overcome these problems by identifying and accommodating for the patient's needs, their normal sleep patterns, and their sleep rituals and routines, many of which are highly individual. Some people have established bedtimes. Others vary their bedtimes according to their level of fatigue. Some clients need silence and total darkness in order to sleep, and others sleep best with music or white noise. Still more go to sleep with a cup of warm milk or decaffeinated tea. Providing measures to promote sleep and rest. The promotion of sleep often depends on correcting the problem that causes the sleep disruption whenever possible, and also providing a quiet, peaceful, and environmentally comfortable environment that promotes sleep and rest, encouraging sleep reduction and relaxation exercises, administering analgesics to reduce pain, and providing a soothing back rub. Scheduling client care activities to promote adequate rest and sleep. Some scheduling suggestions to promote adequate rest and sleep include encouraging a regular bedtime and wake time, encouraging daytime exercise, limiting daytime naps, and discouraging exercise, caffeine, and other stimulants before bedtime. Pharmacological therapies. The practical vocational nurse provides care related to the administration of medications and monitors clients who are receiving parenteral therapies. Licensed practical nurses must be able to perform calculations needed for medication administration, reinforce education to client regarding medications, evaluate client response to medication, for example, adverse reactions, interactions, therapeutic effects, follow the rights of medication administration, maintain medication safety practices, for example, storage, checking for expiration dates, and compatibility. Reconcile and maintain medication list or medication administration record, for example, prescribed medications, herbal supplements, or over-the-counter medications. Collect required data prior to medication administration. Administer medication by oral route. Administer intravenous piggyback secondary medications. Administer medication by gastrointestinal tube, for example, G-tube, nasogastric in G-tube, G-button, or J-tube. Administer a subcutaneous intradermal or intramuscular medication. Administer medication by eye, ear, nose, inhalation, rectum, vagina, or skin route. Count narcotics, controlled substances. Calculate and monitor intravenous IV flow rate. Monitor transfusions of blood product. Administer pharmacological pain medication and maintain pain control devices, for example, epidural, patient control analgesia, or peripheral nerve catheter. Indications, interactions, therapeutic effects, precautions, adverse effects, side effects, and other common pharmacological considerations. Before we begin this major section, let's start with some basic definitions and terminology relating to pharmacology. Indications are the intended uses of a particular medication. Interactions include the results of a medication's interaction with another drug or medication, foods, and lifestyle choices such as alcohol consumption. Side effects are the effects of a medication other than the expected therapeutic effects. Some side effects, such as nausea and vomiting, are primarily harmless and only slightly troublesome. Others can be more severe and troublesome to the patient. Adverse reactions are serious life-threatening side effects to a medication. Medications are discontinued when an adverse reaction occurs. Therapeutic effects are the desired therapeutic effects of a medication. Idiosyncratic effects are unusual responses to a medication that are particular to a patient. Cumulative effects are effects of a drug that occur when it builds up in the body because of poor metabolism of the drug and/or poor excretion of the drug. Cumulative effects can lead to an inadvertent overdose of a medication. A potentiating effect is an additive, synergistic effect that results when two drugs are taken by the patient. One or both of these drugs will have additive greater effects. An inhibiting effect results when a combination of two or more drugs decreases the effect of one or both of these drugs. Precautions are patient conditions that indicate that another medication would be a better choice. Contraindications are patient conditions that prohibit the safe use of a particular medication. The drug's trade or brand name is the manufacturer's name of the drug. The drug's generic name is the formal name of the drug. One generic name can have more than one trade or brand name. Drug absorption is the action that occurs when the drug moves through the digestive tract and becomes absorbed into a form that can be used by the body. Drug distribution, which occurs after drug absorption, is the movement of the medication to the targeted area via the circulation. Drug metabolism or biotransformation is the breakdown of a drug by the liver. Drug excretion is the elimination of the drug from the body. Most drugs are excreted by the kidney and the urinary system. An anaphylactic reaction is a life-threatening allergy response to a medication, most often penicillin. Identifying potential and actual incompatibilities of client medications. Incompatibilities of medications are numerous. It is, therefore, highly recommended that you look up a possible incompatibility using a reliable chart of incompatibilities supplied by your healthcare facility or found on the Internet. Identifying the contradictions to the administration of a prescribed or over-the-counter medication to the client. Many medications, including prescribed and over-the-counter medications, can be contraindicated for clients for a number of different reasons. Nurses must be thoroughly knowledgeable about all aspects of the medications that they administer. Therefore, it is the nurse's responsibility to hold any medication that is contraindicated for the patient until the order is clarified with the patient's ordering physician. Identifying the symptoms of an allergic reaction. Nurses observe for and identify any possible allergies to the medications. All allergies are documented in the nursing assessment and also on the medication administration record, in addition to other areas in the medical record, according to the facility's policy and procedure. Many healthcare agencies also use allergy bands and/or barcodes with embedded allergy information to enable nurses to readily identify any allergies to medications. Commonly occurring medication allergies include allergies to penicillin, which can be particularly dangerous and life-threatening, allergies to sulfonamides, and allergic reactions to cephalosporin medications. It is estimated that about 10% of people have had a reaction to penicillin. Some of these actions are an allergic response to the penicillin, and others are simply a side effect of the penicillin. The first exposure to penicillin, referred to as the sensitizing dose, sensitizes and prepares the body to respond to a second exposure or dose. The signs and symptoms of this allergic sensitizing dose response include a body-wide rash and itching. It is this second exposure or dose that leads to anaphylaxis or anaphylactic shock. The signs and symptoms of anaphylaxis and anaphylactic shock, a type of distributive shock, are the massive collapse of venules and arterioles in the body's circulatory system, decreased cardiac output, histamine release, a drop in blood pressure, pooling of venous blood, laryngeal edema, respiratory distress, a rash, a rapid bounding heartbeat, and death unless it is immediately treated. All allergic responses, including those secondary to medications, must be immediately documented and reported to the doctor and other members of the healthcare team, as indicated and according to the facility's specific policies and procedures. Implementing procedures to counteract adverse effect of medications. Procedures to counteract the adverse effect of medications depend on the patient's adverse responses. For example, constipation will be symptomatically treated, and severe life-threatening adverse responses are treated with the ABCs and other emergency, life-saving measures as in the case of when anaphylaxis occurs. At times, the dosage of the medication will be decreased, the medication will be discontinued, and/or the client will be safely re-challenged with the medication under the supervision of the physician to confirm the adverse reaction. Re-challenging is not done when a severe allergic response is suspected. All adverse drug reactions are reported and documented according to the facility's policies and procedures. Withholding a medication dose if the client experiences an adverse effect to a medication. Nurses must withhold a medication when the client experiences and/or is possibly experiencing an adverse effect to a medication. In addition to holding the dose or stopping the intravenous flow of the intravenous medication, the nurse will notify the registered nurse and/or the doctor and completely document the adverse reaction. Monitoring and documenting the client's response to actions taken to counteract the adverse effects of medications. After treatment to counteract the adverse effects of medications are rendered, the nurse will monitor and document the client's responses to these treatments. Monitoring the client for actual and potential adverse effects of medications. This monitoring for actual and potential adverse effects of medications is done not only for prescribed, doctor-ordered medications, but also for supplements, herbs, and all over-the-counter medications. Monitoring the anticipated interactions among client-prescribed medications and fluids. Nurses also monitor the anticipated interactions of prescribed and over-the-counter medications and fluids, including those interactions that can occur among oral, intravenous, subcutaneous, intramuscular, and even topical medications. These interactions are also reported and documented according to the facility's specific policies and procedures. Monitoring and documenting the client's side effects to medications. Side effects are the effects of a medication other than the expected therapeutic effects. Some side effects, such as nausea and vomiting, are primarily harmless and only slightly troublesome, but many others can be more severe and troublesome to the patient. Documentation and reporting are also done when a side effect has occurred or it is suspected that a side effect has occurred. Monitoring and documenting the client's responses to the management of medication side effects. As previously discussed, prescribed, over-the-counter, and herbal supplements have potential side effects. Nurses monitor and document client responses to any and all interventions that were used to manage any side effects that the client may experience. For example, the nurse will monitor the patient's responses to interventions, such as an enema, that are used to treat the side effects to medications like constipation secondary to opioid analgesic medications. Reinforcing client teaching on the possible effects of medications. Patients and significant others must be knowledgeable about all of the medications that the patient is taking, including the signs and symptoms of side effects and adverse reactions. They should also be instructed about when to call their doctor to report suspected side effects and adverse reactions. Notifying the primary healthcare provider of actual, potential adverse effects of client medications. Nurses must document and notify the primary healthcare provider about any actual or potential adverse effects and side effects of medications. Dosage calculations. Safe nursing care mandates accuracy in the calculation of dosages and solution rates. The three measurement systems that are used in pharmacology are the household measurement system, the metric system, and the apothecary system. The household measurement system is typically only used for patients who are in the home and not in a hospital or another healthcare facility. Measurements used in the household measurement system include teaspoons, tablespoons, drops, ounces, cups, pints, quarts, gallons, and pounds. The apothecary measurement system has weight measurements like dram, ounce, grain, gr, scruple, and pound. The volume units of measurement in the apothecary measurement system are a fluid ounce, a pint, a minium, a fluid dram, a quart, and a gallon. The metric measurement system has volume measurements including liters, cubic milliliters, and cubic centimeters. Its units of weight are kilograms, grams, milligrams, and micrograms, mcg. Each of these measurement systems can be converted to another measurement system by using equivalents. The most common conversions from one system to another with its accurate equivalent are: 1 grain is equal to 60 milligrams. 1 kilogram equals 2.2 pounds. 1 milligram equals 1,000 micrograms. 1 gram equals 1,000 milligrams. 1 kilogram equals 1,000 grams. 1 tablespoon equals 3 teaspoons. 1 tablespoon equals 15 milliliters. 1 teaspoon equals 5 milliliters. 1 liter equals 1,000 milliliters. 1 ounce equals 30 milliliters. The ratio and portion method is the most popular method for calculating dosages and solutions. Here is how the ratio and proportion method is done for medication dosage. The doctor's order is to give 500 milligrams of an oral medication 1 time a day. The label on the bottle states that each tablet contains 125 milligrams. How many tablets should be administered daily? The problem is solved by doing this. 500 milligrams is to X tablets equals 125 milligrams is to 1 tablet. You then multiply 500 milligrams times 1, which equals 500 milligrams x 1 equals 500 milligrams. 125x equals 500 milligrams. X equals 500. 125. Or 500 divided by 125 equals 4 tablets. Intravenous fluids. Doctor's order: 0.9% NaCl solution at 50 milliliters per hour. How many GTTs per minute should be administered if the tube delivers 20 GTT per milliliter? X GTTs per minute equals 50 times 20 over 60 equals 1000 over 60 equals 16.6 GTT. Rounded off to 17 GTT a minute. Rounding off decimals. When calculating doses, you round up a number when the number to the right of it is more than 5 or more by adding 1 to the number. When the number to the right of it is 5 or less, you do not change the number. So if you are rounding a 3.68 to the nearest tenth, the answer is 3.7 because 8 is more than 5. And if you are rounding off 3.22 to the nearest tenth, the answer is 3.2 because 2 is 5 or less. Similarly, if you are rounding of 3.687 to the nearest hundredth, the answer is 3.69 because the 7 in the hundredths place is more than 5. And if you are rounding off 3.222 to the nearest tenth, the answer is 3.22 because the 2 in the hundredths place is 5 or less. Using clinical decision-making when calculating doses. Nurses apply clinical decision-making skills to these calculations. The nurse should be alerted to the fact that a dosage calculation is wrong when the calculation is solved and it says that the nurse should be administering 8 tablets. In practice, rarely more than 2 tablets are given. If a higher dose is needed, tablets containing a higher dose are used so that fewer pills or tablets have to be given. Similarly, nurses should be alerted to the fact that a dosage calculation is wrong when the calculation is solved and it says that the nurse should be administering 2½ milligrams of digoxin because the nurse has the knowledge that this dosage of digoxin is much higher than the safe dosage. Lastly, nurses should be alerted to the fact that a dosage calculation is wrong when the calculation is solved and it says that the nurse should be administering 300 drops per minute of an intravenous fluid because it is impossible to accurately count these rapidly falling drops. The nurse must recalculate or recalculate with another nurse when things like this occur. Expected actions and outcomes. Identifying the client's expected response to medication. All medications have expected outcomes and therapeutic effects, but they also have other effects like a cumulative effect, a potentiating effect, an inhibiting effect, an idiosyncratic effect, and adverse effects. Nurses administering medication must monitor clients and identify the client's therapeutic responses to medications among other non-therapeutic and unexpected effects. For example, the patient's potassium level should decrease when they are given K-acylate. All effects, including expected responses, are documented. Using resources to check on the purposes and actions of pharmacological agents. Some of the reliable resources that nurses can use to access information about a client's medications are the Physician's Desk Reference, PDR, a nurse's drug handbook or textbook, the facility's formulary, and a pharmacist. These resources contain full information about medications, including their purposes, actions, dosage, side effects, and other details. Applying a knowledge of pathophysiology when addressing client pharmacological agents. Nurses apply knowledge of pathophysiology when they are addressing the patient's pharmacological agents. The indications for a patient medication are closely aligned with the pathophysiology that is affecting the patient. For example, anticoagulant indications are closely aligned with pathological prolonged clotting, and antibiotic indications are closely aligned with the pathological growth and multiplication of pathogenic infective microorganisms. Monitoring the client's use of medications over time. Nurses monitor the client's use of medications over time in terms of their compliance and the continued efficacy of prescribed medications, over-the-counter medications, and home remedies to achieve the desired therapeutic effects. Reinforcing education to the client regarding medications, including the reinforcement of teaching about the actions and therapeutic effects of medications and pharmacological interactions. Nurses reinforce education relating to all aspects of the medications that the patient is taking when a knowledge deficit is identified. Evaluating client response to medications. Again, the licensed practical nurse observes, identifies, and documents all responses to medications. Medication administration. Identifying the client's need for PRN medications. A PRN medication is given when a specified condition in the order presents. For example, a PRN pain medication is given when pain is present, and an antipyretic is given when the patient's temperature is more than 100 degrees. In addition to documenting that a PRN medication was administered, the nurse should also document the data that indicated the need for the PRN medication. Mixing client medications from 2 vials as necessary. Medications can only be mixed together when they are, like NPH and regular insulin, compatible. The procedure for mixing NPH and regular insulin is to instill an amount of air into the NPH bottle that is equal to the NPH dose, and then inject an amount of air into the regular insulin bottle that is equal to the regular insulin dose. Now, withdraw the regular insulin dose and then withdraw the NPH dose using the same insulin syringe. Medication safety. Following the rights of medication administration. The 10 rights of medication administration are the right or correct. 1. Patient. 2. Medication. 3. Dose. 4. Time or frequency. 5. Route. 6. Client education. 7. Documentation. 8. Right to refuse. 9. Assessment. And 10. Evaluation. Maintaining medication safety practices. In addition to the 10 rights of medication administration and identifying the patient using at least 2 different identifiers, nurses must also ensure medication safely in respect to the storage of medications, the checking for expiration dates, checking for any patient allergies, and checking for any incompatibilities. Narcotics must be in a locked and secure place. Other medications must be stored in a place that is secure and one that prevents accidental poisonings among the pediatric population and also among those who are confused and/or cognitively impaired. Additionally, medications that need refrigeration must be refrigerated. Reconciling and maintaining a medication list or medication administration record. Medication reconciliation is a process that maintains a list of all current medications, including all prescription medications, vitamins, over-the-counter medications, herbal remedies, and nutritional and/or dietary supplements. Collecting the required data prior to medication administration. Nurses collect and check pertinent data prior to administering a medication. For example, the nurse checks and documents the apical heart rate before giving digoxin. The nurse checks blood pressure before giving an antihypertensive. Nurses also check blood glucose before administering insulin. Assisting in preparing the client for the insertion of a central line. Nurses are sometimes asked to assist with invasive procedures such as the placement of a central venous catheter or the placement of a respiratory tube such as an endotracheal or tracheostomy tube. Sterile procedure and a sterile field, as detailed previously, are used for these procedures and care. Administering medications by the oral route. The nurse will identify the patient, inform the patient about the medication that you will be giving, and then give the oral medication to the patient and remain with the patient until the medication is swallowed. Administering intravenous piggyback medications. The nurse will identify the patient, inform the patient about the medication, and ensure that the IV solution is compatible with the piggyback medication. The piggyback is hung, the primary IV site is cleansed with alcohol, the piggyback is inserted into the primary IV line, and then the primary IV and the piggyback are then allowed to run together until it is done. Administering medications by a gastrointestinal tube. After positioning the patient in the Fowler's position and verifying that the tube is properly placed, the procedure for administering medications by a gastrointestinal tube is 1. Insert the syringe without the piston into the end of the nasogastric tube. 2. Pour the medications into the syringe and let it flow freely with the natural force of gravity. 3. After the medication is completely administered, instill 30 to 50 milliliters of water to flush the tube, and 4. Keep the patient in the Fowler's position for at least 30 minutes after the administration of the medication in order to prevent any aspiration. Administering medications by the subcutaneous route. The steps for administering a medication with the subcutaneous route are 1. Clean the injection site with an alcohol swab in an outward circular pattern of about 2 inches. 2. Pinch the site for a 1-inch fold. 3. Position the needle with the bevel up and insert the needle at a 45-degree angle. 4. Pull the plunger back to check for blood. 5. Slowly inject the medication. 6. Withdraw the needle and cover the site with an alcohol swab. And 7. Gently massage the site, except when heparin was administered. Administering medications by the intramuscular route. The steps for administering a medication with the intramuscular route are 1. Clean the injection site with an alcohol swab. 2. Position the needle with the bevel up and insert at a 90-degree angle. 3. Pull the plunger back to check for blood. 4. Slowly inject the medication. 5. Withdraw the needle and wipe the site with an alcohol swab. And 6. Gently massage the site except for certain medications. Administering eye medications. The steps for administering eye medications are 1. Ask the patient to tilt their head back and towards the eye getting the drops or ointment. 2. Rest your hand against the client's forehead to steady it. 3. Pull the lower lid down and instill the ordered number of drops. And 4. Ask the person to now close their eyes and then blink so the drops will spread over the eye. Administering ear medications. The procedure for administering ear medications is 1. Warm the eardrops to body temperature. 2. Have the patient lie on their side with the ear to get the medication up. 3. Straighten out the ear canal by pulling the auricle up and back. You should pull the auricle down and back for pediatric patients less than 3 years of age. 4. Instill the ordered drops against the side of the inner ear and hold the auricle in place until the medication is no longer visible. And 5. Have the person remain in the side-lying position for at least 10 minutes. Administering medications by the inhalation route. The steps to using a metered dose inhaler are 1. Shake the bottle and remove the cap. 2. Ask the person to exhale. 3. Have the person then firmly place their lips around the mouthpiece. 4. Release the medication while the person is taking a long, slow inhalation. And 5. Have the patient hold their breath for a couple of seconds and then slowly exhale. The steps to using a turbo inhaler are 1. Slide the sleeve away from the mouthpiece. 2. Turn the mouthpiece counterclockwise in order to unscrew it. 3. Place the colored part of the medication into the stem of the mouthpiece. 4. Rescrew the inhaler. 5. Slide the sleeve all the way down to puncture the capsule. 6. Tilt the head backwards, and after a full exhalation, tell the client to deeply inhale and hold their breath for several seconds. And 7. Repeat inhalations until all of the medication has been used. Administering medications by the sublingual and buccal routes. Buccal medications are placed between the teeth and the inner aspect of the cheek. Sublingual medications are administered under the back of the tongue. Administering medications by the vaginal route. The procedure for administering medications vaginally is: 1. Position the patient in the lithotomy position. 2. Lubricate the vaginal suppository with a water-soluble jelly. And 3. Spread the labia and insert the suppository about 3 inches into the vagina. Administering medications by the rectal route. The procedure for administering medications rectally is: 1. Position the patient in the left Sims position. 2. Lubricate the rectal suppository with a water-soluble jelly. 3. Lift the person's upper buttock with a non-dominant hand and insert the suppository with the tapered end first into the rectum about 3 inches. 4. Ask the patient to lie still so the suppository can be retained. And 5. If the person has the urge to defecate, place a gauze pad over the rectum and press until the urge to defecate passes. Disposing of client unused medications according to facility agency policy. Unused and expired medications are disposed of according to the facility's policy. Counting narcotics and controlled substances. Controlled substances and narcotics are immediately documented on the narcotic record when they are taken from their secure and double-locked cabinet. This documentation is not done after the medication is administered. Narcotics and controlled substances are then documented in the patient's medication record as soon as they are administered. If a controlled substance is wasted, this waste must be witnessed by and documented by the wasting nurse and another nurse. During the change of shift, 2 nurses perform a complete count of all narcotics and controlled substances. If a discrepancy occurs, it is immediately reported for further investigation. Calculating and monitoring intravenous IV flow rates. The calculation and monitoring of intravenous flow rates were previously detailed under dosage calculations. Monitoring the transfusion of blood products. The 4 blood types are types A, B, AB, and O. Type A blood is compatible with types A and O blood types. Type B blood is compatible with types B and O blood types. Type AB blood is compatible with types A, B, AB, and O blood types. Type O blood is compatible only with type O blood. Blood is also classified as Rh negative or Rh positive. This Rh compatibility is also essential to safe blood administration and to prevent hemolysis. Whole blood and blood products such as packed red blood cells, platelets, clotting factors, and plasma are administered to clients for a number of different reasons, including platelet disorders, chronic renal failure, anemia, coagulation disorders, and hemorrhage. Blood transfusions can be a homologous transfusion or an autologous blood transfusion. Before blood transfusions, the patient laboratory values are checked. The doctor's order is checked. The patient's blood is typed and cross-matched, and the blood is obtained from the blood bank just prior to administration. Just prior to the administration of the blood or blood product, 2 nurses identify the patient using 2 unique identifiers, ensure that the 20-gauge intravenous line is patent, prime the intravenous line with normal saline, and attach the filter if ordered. Inspect the blood for abnormalities. Check the expiration date and time and ensure that it is not expired, and check the compatibility of the blood, the client's blood type, and cross-match. 1 nurse must stay with the patient for at least the first 15 to 30 minutes after the transfusion has begun to monitor for any reactions to the blood, which typically occur shortly after a transfusion has begun. Vital signs are checked at least every 15 minutes for at least 1 hour, and then every hour after that. The blood transfusion rate is monitored and deemed sufficient enough to complete the transfusion within 2 to 4 hours after it began. The patient is also monitored for any signs of reaction to the blood. Some of these signs and symptoms can include level of anxiety, respiratory distress, and neck vein distension. Some of the complications of blood and blood product administration include sepsis, which can be signaled with nausea, vomiting, fever, hypotension and abdominal pain, circulatory overload, which can be signaled by chest pain, hypertension, crackles, edema, anxiety, neck vein distension, dyspnea and trachypnea, and hemolysis, which can be present with dyspnea, hypotension, anxiety, chest pain, and back pain. Blood transfusions are immediately stopped when a possible blood reaction is occurring. The doctor must be notified, and any necessary emergency interventions are provided as indicated by the patient's condition. The blood bag and the administration tubing are kept for possible testing and analysis whenever a reaction to a blood transfusion has occurred. Reinforcing client teaching on client self-administration of medications. Nurses reinforce education relating to all aspects of the medications that the client is taking, as previously mentioned. Some examples of this education reinforcement include asepsis, mixing insulins, drawing up of insulin, proper subcutaneous injection procedures, and the proper use of an insulin pump. Pharmacological pain management. Patient reports of pain are far more accurate and reliable than other pain assessments, like those related to behavioral changes. Pain can be categorized in a number of different manners. Pain can be classified acute and chronic. Pain can also be categorized as nociceptive and neuropathic. Pain can be also described as superficial, somatic, radicular, referred, or visceral pain. Lastly, it can be classified as localized or diffuse, and as mild, moderate, or severe. Acute pain is short-lived and often self-limiting and possibly even correctable. Acute pain lasts usually less than 3 months in duration. Acute pain usually has an abrupt and sudden onset. Acute pain is usually confined to a localized area that can be identified by the patient. Some of the signs and symptoms of acute pain are tachycardia, anxiety, muscular tension, increased blood pressure, diaphoresis, and pupil dilation. Acute pain warns the body that something is physically wrong. Chronic pain is long-lasting, and it usually cannot be completely eliminated. Chronic pain is more difficult to identify and more difficult to measure in terms of its intensity than it is for acute pain. Chronic pain is also more difficult to locate than acute pain. Cancer pain, or malignant pain, is often intraceable. Other subcategories of chronic pain are non-malignant pain, continuous chronic pain, and intermittent chronic pain. Unlike acute pain, there are usually no vital sign changes with chronic pain. However, chronic pain is often accompanied with emotional responses such as anorexia, insomnia, irritability, depression, and fatigue. Nociceptive pain can be somatic or radicular. Nociceptive pain, which occurs with an injury, like a hip fracture, sends a signal to the intact central nervous system that an injury has occurred. Unlike nociceptive pain, neuropathic pain often occurs when the nervous system has been damaged. The source of the nociceptive pain cannot be readily identified and located. Nociceptive pain can be reported by the patient as sharp, severe, burning, and spasmodic. Central neuropathic pain occurs as the result of damage to the central nervous system, such as a spinal cord injury. Peripheral neuropathic pain occurs with peripheral nervous system damage, such as occurs with neuropathy, carpal tunnel syndrome, and post-amputation phantom pain. Lastly, sympathetically medicated pain occurs when there is an abnormal pathological connection between the sympathetic nervous system and nerves. Uncontrolled pain leads to grave and serious consequences, such as a decreased quality of life, social withdrawal, depression, anxiety, diaphoresis, muscular tension, pallor, nausea, vomiting, restlessness, crying, moaning, sleep disorders, suffering, lassitude, sedation, fatigue, insomnia, anger, anorexia, immobility, exhaustion, and even neurogenic shock. It also affects the patient's vital signs. These vital sign changes include increased blood pressure, an increased pulse rate, and an increased respiratory rate. There are many myths and misconceptions about pain, the pain experience, and pain management. Some people believe that pain is expected whenever the person has an illness or injury. Others believe that pain medications cause addiction. Still more think that neonates and infants are not able to feel pain. And others believe that the elderly have inevitable pain because of the aging process. These myths are false and not true. The American Nurses Association's position statement on the use of pain medications at the end of life supports the ethical use of opioids at the end of life to relieve pain if the use of these medications hasten death. Administering pharmacological pain medications. Analgesics are medications that are used to help alleviate pain. Analgesics are categorized into two separate categories, which are the opioid analgesics and the non-opioid analgesics. Opioids are narcotics that are used for severe pain. Non-opioid analgesics are used to treat mild and moderate pain. Pharmacological pain medications are typically ordered and administered on a PRN basis. The nurse determines the patient's level of pain before and after the administration of an analgesic. Identifying the client's need for pain medication. Pain is identified with subjective and objective data. Subjective reports of pain by the patient are more reliable and accurate than the signs and symptoms that are observed by the nurse. For example, a client's report of severe abdominal pain is a more reliable indicator of pain than a nurse's observation that the patient is crying, splinting, and is not able to perform their activities of daily living. Nonetheless, some of the other behavioral indications of pain include deep breathing, guarding, muscular tension and rigidity, the loss of appetite, a loss of sleep, a lack of ability to perform activities of daily living, a lack of focus of attention, and crying. Some of the biological and physiological objective signs and symptoms of pain are an increased pulse, diaphoresis, increased blood pressure, increased or decreased rate and depth of respirations, and the dilation of the pupils. The PQRST acronym is useful to remind nurses of the pain-related data that is collected. P stands for what provoked or precipitated the symptoms. Q stands for the quality of pain. Is it burning, aching, stabbing, sharp, dull, etc.? R stands for what region or area the pain is in. Does the pain radiate to another area? S stands for severity and intensity of the pain. T stands for the things that trigger the pain. Some of the questions that the nurse asks the patient about their pain and their level of pain include questions such as, where is the pain? Describe your pain. When did the pain begin? What precipitates the pain? What relieves the pain? What makes the pain worse? How often does the pain occur? Tell me the character of the pain. For example, is the pain crushing, sore, stabbing, etc.? How would you rate your level of pain from 1 to 10? Monitoring and documenting client responses to pharmacological interventions. Client responses to pain interventions can be calculated in a number of different ways, including the use of pain rating scales, verbal reports of pain, and an objective determination and evaluation of any physical and/or behavioral cues that can be associated with the patient's pain. The level of pain should be determined prior to the administration of pain drug, and the level of pain must also be determined after the medication was administered in order to determine whether or not it was effective in terms of a decrease in the patient's level of pain. Maintaining pain control devices. Nurses also play an important role in maintaining pain control devices such as an epidural pain control, patient-controlled analgesia, and peripheral nerve catheter. Patient-controlled analgesia is defined as the use of a patient-controlled analgesia infusion pump that is used to deliver analgesia intravenously or epidurally to clients in acute or chronic pain. Patient-controlled analgesia, including the intravenous pump, is the most commonly used pain management device. Patient-controlled analgesia devices are pre-programmed electronic devices that are set for the prescribed dosage of a pain medication. The patient activates the device when they are in pain. The prescribed dosage of the medication is then automatically administered unless the next dosage is not yet due. Some patient-controlled analgesia devices beep to let the patient know that the pain medication was not delivered because their next dosage of the medication is not yet due. Some of the advantages of patient-controlled analgesia include the rapid relief of pain, the self-control and self-administration of a pain medication when the patient wants it, and the delivery of the pain medication within prescribed limits. The disadvantages of patient-controlled analgesia include the fact that some patients, like confused or lethargic patients, may not be able to use and manipulate the patient-controlled analgesia device. In some cases, another person can be authorized to press the button and deliver the pain medication when the patient is not able to do it by themselves. The use of the patient-controlled analgesia device by another person, a surrogate, must be authorized by the doctor who has ordered the analgesic medication before the surrogate is able to assist the patient with the patient-controlled analgesia. Epidural analgesia is most often used among patients who have chronic uncontrollable back pain when other interventions, such as other medications and the services of a physical therapist, have not been effective. These epidural injections are sometimes done in a community-based doctor's office with or without the guidance of an X-ray. The expected outcome for epidural analgesia, like all other pain management techniques, is a decrease in the patient's level of pain after the procedure is done. Peripheral nerve blocks using a peripheral nerve catheter are most often used for anesthesia, but they can also be retained and used for a continuous infusion of analgesia postoperatively.